Good morning. Thanks. Thank you for joining us at the Rocky Mountain MS Center's 2014 Education Summit. We truly appreciate you choosing to spend your day with us. My name is Gina Berg, and I'm CEO of the Rocky Mountain MS Center. On behalf of our board of directors, staff, physicians, and volunteers, I'd like to welcome you here today. We've worked hard to put together this program, and we hope it's a morning that will be full of learning for everyone. I'm excited to be here with you because the Rocky Mountain MS Center is truly a patient-centered organization. We're focused on providing comprehensive and integrated wellness approach to treating MS, and we accomplish this through offering a unique scope of programs and services. We're committed to you, be it patient, caregiver, or provider, to make sure that we provide you with the resources that you need. My commitment to the success of the center stems from a personal place, a connection with our mission. I have family members who have fought and are fighting this disease. In fact, just this last week, my aunt came to our center for a tour, and we talked about how different the landscape has changed and looks from 30 years ago when we walked this journey with my great uncle. My hope today is that the summit reminds us of how far we've come, gives us support for where we are, and guides us to where we want to go. Our mission is to improve the quality of lives of individuals and their families living with MS and related neurological diseases through care, support, education, and research. Today you'll hear how we're putting that mission into action. We'll begin this morning with presentations by some of our doctors from the Rocky Mountain MS Center Clinic at the Anschutz Medical Campus. These presentations will provide overviews of the latest information on symptoms management, disease-modifying therapies, the causes, effects, and patterns of MS, and our innovative model of maximizing lifelong brain health. Following these presentations, we'll be breaking off into smaller discussion groups with MS experts from various disciplines. From one-of-a-kind hydrotherapy program to legal services helping our clients navigate the Social Security disability systems, our programs work together to form a comprehensive scope of care. Our vision is that this approach will be the model for future MS treatment. We hope that you'll enjoy the opportunity to customize your day with us. Before we get started, though, I'd like to call your attention to one item in the folder you received this morning. It's an evaluation form. You don't have to pull it out right now, but I want you to know it's there. It's very important to us. Please, I encourage you before you leave today to take a moment to fill that out. We're constantly looking to make these events engaging, informative, and useful to you, and we'd love your opinion so that we can continue to make that happen. Also, if you have any questions today, want to learn more about the work we do, please feel free to speak with me. I'm here all day, or any of our staff members. And right now, I'd like to highlight one of our staff members, Sarah Camassione, our education coordinator. Sarah, if you could give us a wave. Sarah has worked very, very hard to put together this event today. Thank you for all of your hard work. Once again, thank all of you for being here. I hope that our Education Summit today exceeds your expectations. I'd like to introduce our MC for today, Michelle King. Michelle is the director of our King Adult Day Enrichment Program, where as many as 70 clients a day come together for a wide variety of classes, programs, and activities. Michelle ensures that KDUP remains a great place for our clients to enhance their physical, emotional, cognitive, and social well-being. KDUP is just one example of the innovative approach to lifelong care that we focus on at the Rocky Mountain MS Center. Michelle and our dedicated staff make sure that that happens every day. Michelle?
Thank you, Gina. Good morning, and thank you all for being here. I just want to take care of a few housekeeping items. If you have a cell phone or any electronic device, if you could turn it off or put it on silent so it doesn't disrupt those around you. Also, a reminder that the restrooms are out the doors and to the right. In your folder, you will find a note card. Those note cards are intended for you to write questions for the question and answer session. Our volunteers will be circulating to pick those up to make sure your questions get answered. Please join me in introducing Dr. Augusto Miravalli, an MS specialty neurologist from the University of Colorado, who's going to talk to us about the epidemiology of MS.
Thank you. Thank you, Michelle, and thank you, Gina and Rocky Mountain MS Center for allowing me to speak today. Can you hear me in the back? Let's do this. Can you hear me now? Okay. So thank you for the invitation to speak here. It's a pleasure being here. And thank you for coming in a Saturday morning, beautiful day, bright and early. But I think the reason why we are all here is because we understand that the most powerful treatment for multiple sclerosis is knowledge. When we have knowledge, we truly empower ourselves and our patients to take control of this disease. So this is one of my favorite talks in the year because we truly enjoy being able to summarize what we all learned in the last year in meetings, in conferences, in papers, and put together a presentation for you to make sure that you are up to date in what we believe is the latest knowledge in multiple sclerosis. And my talk today has to do with the cause of MS. What causes multiple sclerosis? And let me tell you that we don't know yet, but we are very close to having an answer to that question. And I will walk you through the causes of MS, risk factors, what makes somebody have a higher risk of multiple sclerosis, and what makes somebody with MS have a higher risk of progressing with the disease. So that's what we call epidemiology of multiple sclerosis. So we know that there are currently over 500,000 people in the US with multiple sclerosis. And that accounts for 2.3 million people in the world. In Colorado, we estimate that it's close to 12 to 13,000 patients with MS. 80% of patients with multiple sclerosis will develop the first symptoms anywhere between their teens to their 30, 40 years old. But as you know, MS can be diagnosed as early as infantile multiple sclerosis and as late as 60 to 70 years old. So there is a very big variability in the presentation of multiple sclerosis. We still see that there is a female to male preponderance of the disease, and that ratio continues to grow, probably as a result of females having better access to health care and having better access to having the correct diagnosis of the disease. But currently, we estimate that the ratio is 2.4 to 1, 2.4 women to 1 male with multiple sclerosis. What happens if we don't treat the disease? What happens if we don't intervene with medications, with treatments, with approaches, with physical therapy? Well, we know that the disease will continue to progress at a very steady rate. And even though there is variability, we know that most patients will accumulate disability that will result in the use of cane or assisted devices for ambulation in 50% of the cases, anywhere from 5 to 10 years from onset. We know that 30% of patients, if not treated, will require the use of wheelchair at some point in their life. And we know that without treatment, MS will shorten the lifespan of those patients. But we also know that with treatment, with the right treatment, the life expectancy of patients with multiple sclerosis is the same as people without multiple sclerosis. So that's a very concrete outcome that we can measure and actually give us an idea of how effective these therapies are for multiple sclerosis. As you may know, MS is very costly. The healthcare cost estimated for patient for multiple sclerosis for the total economy for the US is $9.4 billion a year. And as you know, it's the leading cause of disability among young women and the second leading cause of disability in young men in the United States of America. So let's start talking about the cause of multiple sclerosis. We know that there is not just one cause, one factor that will cause a disease, but it's a combination of factors. It's environmental factors like viruses, genetic factors, as well as other risk factors that I will talk today. Let's talk about risks. Who has a higher risk of multiple sclerosis? Well, over years, we learned that MS is primarily a disease that affects white people, Caucasians, particularly people coming from some sort of European ancestry. Northern European countries have the highest incidence of MS, but also in the US, we have one of the highest incidence of MS in the world. Conversely, we know that Black and non-Hispanic individuals, actually Hispanic individuals have a lower risk of multiple sclerosis. But interestingly, as MRIs become more available and healthcare becomes a little bit more available in certain countries, we see that the incidence of MS start to increase in those countries. So probably the reason why we don't see MS in those populations has to do more with socioeconomic factors rather than a true genetic difference. We know that the concordance of MS in monozygotic twins is 25%. So that means if a patient has a twin and that patient has MS, the twin brother or sister will have a 25% higher rate of developing the disease. And having a sibling with multiple sclerosis also increases the risk of the disease anywhere from 20 to 40-fold. That's a question that we usually get in the clinic. A patient is newly diagnosed with multiple sclerosis, and one of the questions that she or he has is, what's going to happen with my kids? Am I going to pass this disease to my kids? And the answer is no. MS is not a hereditary disease. It's not that you pass the disease, but what happens is that it's possible that there are certain genes that will manipulate the immune system, will create an immune system that is more dysfunctional, and we will talk a little bit later about that. And what happens is that your offsprings, your kids, may inherit those genes. And the combination of those genes plus some environmental factors might increase the risk of MS in your kids. So we usually talk in Colorado, there is an estimated risk of 0.7% to acquire the disease. That risk, if you have a first-degree relative with MS, increases to 3%. So the risk increases, but it's not a large risk. So let's talk about viruses. From the time that Charcot described this disease in the 1800s, people thought, I wasn't alive there, that MS is caused by a virus. And we still think about it. Probably not that the disease is caused by the virus, but the virus somehow play a role in causing or increasing the risk of developing MS. And of all these viruses, the one that causes mononucleosis or mono, the Epstein-Barr virus, seems to be the one that we keep talking about. The reason for that is because mono tends to affect people in the right age group that will increase the risk of MS. And let's talk about that a little bit here. There is a clear relationship between the risk of acquiring Epstein-Barr virus and socioeconomic factors. So countries with better sanitation, with better vaccination campaigns, with lower risk of infections in childhood, people in those countries don't get exposed to Epstein-Barr virus early on. So they usually get exposed to Epstein-Barr virus or mono later on in life. And when you see that, you see an increase of autoimmune responses as a consequence of the exposure to that virus. When you go to countries in Africa or in South America, the incidence of Epstein-Barr virus or mono in childhood, and that means before the age of 15, is higher, and the incidence of autoimmune disorders is lower. So the thought here is that if you exposed your immune system to a virus, in this case Epstein-Barr, early on in life, the immune system has a better chance to respond in a healthy way to that virus. Whereas if the immune system has been protected for years and never been challenged or minimally challenged, typical 99% free bacteria environments in which the immune system is never challenged or minimally challenged, if you expose those individuals later on in life, they have a higher chance of developing an abnormal, unhealthy autoimmune response. So that led to the knowledge of the hygiene hypothesis, which means in places with poor sanitation, with higher risk of infantile infections, they see that there is a lower incidence of autoimmune responses. So I usually explain to my patients, this is a difficult concept to understand. And imagine that your immune system is like a teenager, is a kid. And you allow the kid to grow up in a bubble, never exposed to people, never exposed to anybody. And all of a sudden, you put this kid in college. And he's exposed to all these people, girlfriends maybe, or boyfriends, and doesn't know what to do. So has an abnormal response to people. The same happened with the immune system. The immune system has been protected for so many years. All of a sudden gets exposed to a virus like that and will not know what to do with that. So, and happens to be that Epstein-Barr is one of those viruses that also has a very similar structure to the myelin, to that fatty substance that is going to wrap around the nerves. So when the immune system gets exposed to this virus, then we'll have memory cells. Those cells are going to circulate in people's body looking for anything that looks like this virus. And if they find something similar, they're going to attack that. And because of the similarities between the Epstein-Barr virus and the myelin, we think that that's the reason why this virus might develop or might trigger the development of an autoimmune response to the myelin, and hence multiple sclerosis. That is a process known as molecular mimicry. It means that the immune system gets confused in recognizing between the difference of the virus and your myelin. And that initial exposure to the virus will predispose patients to develop a dysfunctional autoimmune response to the myelin. So one of the largest studies looking at this was here in the US, and look at people from VA hospitals, and literally look at thousands and thousands of people, and they measure if they were exposed to Epstein-Barr. For those who were not exposed to Epstein-Barr, they followed them over time. 10 people that were initially negative to Epstein-Barr acquired the infection. And you see them here. Month after the infection was diagnosed by blood tests, these people developed MS. So there was a clear temporal relationship between acquiring Epstein-Barr or mono in these individuals and development of multiple sclerosis. So when you look at the age of onset of Epstein-Barr or mono and the distribution of age of onset in the world, you see that people that is diagnosed with Epstein-Barr later on in life, meaning in your 30s or over your 30s, which is the light blue or the dark blue, they tend to be in northern places in the world with better sanitation and better socioeconomic status. The same map, almost identical map, is the map of MS. So there is a clear relationship between higher incidence of MS and later exposure to Epstein-Barr virus. So that's why these viruses continue to be in the list of possible culprits for the development of MS. Again, it's not that the virus causes MS, but the virus will make that interaction to the immune system and the myelin that is dysfunctional. So this cartoon tries to exemplify what the molecular mimicry is, and I will not bore you with this slide, but what I want you to take from this slide is that once your immune system gets exposed to something, in this case Epstein-Barr, both types of cells, the T cells and the B cells, are going to respond. And later on you will hear today that we have therapies that actually work on both B cells and T cells. And both cells are very important not only for the development of MS, but also for the treatment of multiple sclerosis. So let's move from viruses now to genes. What happened with the genetic component of multiple sclerosis? So we know now that there are over 110 genes that has been identified that predict or are associated with the risk of the disease. Most of those genes had to do with the way your immune system will respond to certain antigens. And going back to the example of your immune system, let's now imagine that your immune system is like the police in a city. Your immune system is supposed to protect you. It's supposed to chase criminals and protect people from criminals, right? Well, what happened in MS patients is that police, they're a group of police that they get confused and they don't know who to chase, or they don't know to distinguish the difference between a civilian and a criminal. So particularly if they get exposed to something that looks very similar to a criminal, they will chase after that. So there are many stops and control systems to make sure that autoimmune disorders don't occur. And those stops are the ones that are not working well in patients with MS. So everything has a gene associated with that. So all those hard stops usually are proteins or other factors that the genes that will make those proteins are abnormal in MS patients. So again, when you transmit the genes, you're not transmitting the disease, you're transmitting the higher chance of developing an abnormal immune response to that trigger, maybe a virus, maybe something else, that then will increase their chances of an autoimmune response. Is this clear? Because this is a very important concept, and I want to make sure that you understand that, because it took many, many years or decades to truly understand this, and it's a very important piece because from here, we can then understand not only how to treat the disease, but what is happening, how to mitigate those risks for patients. The last bullet has to do with a new gene that we recently learned, that this gene has to do with the vitamin D. So people with lower vitamin D, we know that has increased risk of multiple sclerosis, and I will talk in a few slides about that. But now we also know that there is a gene associated with vitamin D metabolism, and interestingly, that gene is also associated with a higher risk of MS. Going back to race, we know that certain races have a higher chance of MS, but also a different type of presentation. And this is a very interesting story. When you look at multiple sclerosis in the world, Asian countries and South American countries and Native American Indians with multiple sclerosis, they have a very similar pattern, which is different to the typical MS. Those patients tend to have involvement of the eyes and involvement of the spinal cord, predominantly. So something that we call opticospinal multiple sclerosis. Whereas patients in other cultures, in other races, patients from other ethnicities, they have the typical multiple sclerosis with lesions in the brain predominantly. So this opticospinal MS that was first described in Japan, the thought about that is a very similar presentation to another disorder called neuromyelitis optica, and there is a big overlap between the two. When you look at the map of opticospinal MS, you can definitely trace the map of migration that we saw on the Native American Indians. And with Native American, I mean in the entire continent of America. The Native Americans in Patagonia, the Native Americans in Colorado, they have a similar presentation to multiple sclerosis. So it's very possible that this early migration that happened in America also has to do with some predisposition of developing MS with a specific pattern. And those patients also respond differently to certain medications. Medications, for example, like interferons, don't tend to work very well for those patients. In terms of geography and migration, this is another factor that is changing the landscape of multiple sclerosis in the world. And why is that? Well, we talked about genes. We talked about environmental factors like Epstein-Barr. But also, as people move in this planet, it's changing constantly, the incidence, the prevalence, and the risk of acquiring the disease. And when you look at migration in the world, it's very interesting to see the push and pull theory. What makes somebody move? I have a slide here. What makes somebody move out of a country, or what makes somebody come to a country? And usually there are socioeconomic factors more than anything. People from lower economies, people from places that are underdeveloped, they tend to move looking for a better style, better job, and better economy. So naturally, these people is going to bring a lower risk of MS because they were coming from places with higher incidence of infections, lower chance of autoimmune responses, to places that have a higher risk of MS. Conversely, people from better economies tend to move later on in life after they have a stable economy. And the reason why they move is usually looking for better quality of life, better climate. And they are going naturally to places with lower economies, bringing a higher risk of MS because they grew up in places with better sanitation and higher risk of acquiring autoimmune disorders. So this constant flow of migration is now changing the landscape of multiple sclerosis in the world. And we see that we are losing that latitude gradient that we used to see in the past, in which MS was more common in northern places and less common in southern hemisphere places. And probably has to do with this pattern of migration that we are seeing lately. So this is the current prevalence of multiple sclerosis in the world. This is as of 2013. And you see that despite what I just explained, we still say the highest prevalence of multiple sclerosis is still in North America, and as well as in Scandinavian countries and Europe. So this is just to prove, this is an article from The Economist that also supports what I was just explaining, the reasons why people migrate, the push-pull theory. Another factor actually is changing the landscape is the ability for certain places to actually diagnose MS. And we see that the availability of MRIs and doctors actually in poor economies, in countries that are underdeveloped, actually is improving. And is improving at a higher rate than the availability of MRIs and doctors in places with better economies. Probably because places with better economies see this influx of patients coming, looking for better healthcare. So we see that the chances of diagnosing MS is now becoming better in places with lower economies, again changing the incidence and the prevalence of multiple sclerosis in the world. So this is a constant, very dynamic process that as we continue to understand that will continue to contaminate the numbers that we thought we had clear in the past. And now the map of MS is constantly changing. So this is another slide looking at number of MRI machines per 100,000 population in the world. And you see that again, places with higher MRI machines prevalence or better access to healthcare, they tend to have higher incidence of MS, probably for many factors, but better diagnosis is one of them that we shouldn't ignore. So this is to show that the female to male ratio continued to increase. In past decades, we thought that there was 1.5 to 1, and now we are close to 3 to 1, 2.5 to 3 to 1 in certain places. And that probably has to do with, it's not that females have a higher risk of MS and that risk continues to increase. It's probably, again, better access to healthcare. So we talked about viruses, we talked about geography, we talked about genes, and let's now talk about vitamin D. We know now, and it's certain, that vitamin D deficiency predisposes patients to actually acquiring the disease. So it's a risk factor for the disease, but also when somebody has MS, having low vitamin D makes the outcomes worse. So low vitamin D seems to play two roles here: increase the risk of MS, as well as when somebody has MS already, is associated with worse outcomes. And when we talk about deficiency in MS, we talk about levels that are below 50 nanograms per deciliter. So we want to keep those levels anywhere from 50 to 90 nanograms per deciliter. And the levels of vitamin D changes depending on what geography patients are. In Colorado, we find that up to 80% of people is deficient when you consider those standards. And most people require taking extra vitamin D that is at least 5,000 units daily. So we usually start with 5,000 units daily, and we measure the levels 6 months later. It takes up to 6 months to correct the levels. And if the levels are still low, meaning below 50 nanograms per deciliter, we go up in the dose. Sometimes we have to go to 10,000 units daily. So when you look at the map in the world again of places with lower vitamin D, it's almost identical to the map of MS, in which places that has lower vitamin D levels in their individuals, they have a higher risk of MS. What is the role of vitamin D in the immune system? Well, many, as you can see. Vitamin D helps to modulate immune responses that are more protective against autoimmunity. So not having vitamin D will predispose that immune system to be more prompt to develop autoimmune responses. So this is just another study looking at numbers, but I will save you the hassle of reading this very busy slide and tell you that actually vitamin deficiency is associated with worse outcomes in multiple sclerosis. So they follow patients that had the first clinical event, and they randomized patients into patients with lower vitamin D and patients with higher vitamin D at baseline, and they found that the patients that had lower vitamin D levels develop MS earlier. So I just had the 5-minute mark, so I have to actually speed up here. So what I'll do is tell you that salt is bad for MS, so let me just do a poll in the audience. Raise your hand if you think that salt is bad for you. Okay, so you got the picture, right? Salt is bad for MS too. And interestingly, salt, higher salt content in diet, and that means over 2 grams per day, is associated again with increased risk of developing MS, but also once you have MS, higher salt diet are associated with worse outcomes. So going back to your kids, if you have MS and you're worried about their risk of MS, check their vitamin level. Don't put salt in their food. Ask them, please do not smoke, which is the next risk factor that we have here. And probably make sure that you're keeping an eye and surveillance for any neurological symptoms. So let's do the same poll here in the audience. Who thinks cigarette smoking is bad for you? Okay, so you got the second picture. So another risk factors for MS. So smoking increases both the risk of developing MS as well as once you have MS, actually by 10 times worse, the outcomes, the clinical outcomes. So another thing to do if you already have MS, please don't smoke. Check your vitamin D levels. Don't add salt to your food. And Dr. Bolmer will talk more about exercise. Exercise is a wonderful treatment for MS, but we don't know if exercise actually increases or decreases the risk of MS to develop the disease. So that's why I didn't include exercise in my presentation. So how am I doing in time? I have 4 more minutes. Oh, okay, that's good. That was the longest minute I ever had. So, that's the natural history of the disease. And as you are all familiar, you have those yellow arrows in the bottom. Those are the MRI activity. MRI is very, very frequent early on in the process. Patients tend to accumulate a lot of lesions early on. It's usually anywhere from 5 to 10 new lesions every 18 months if the patient does not receive any treatment. So 1 out of those 10 lesions tend to cause symptoms, and that's what we call relapses. And the relapses are those black, I should have a pointer somewhere, somebody told me, but I forgot. So those black squares that you see in the picture. And the red line is the one that we don't like to see, which is the axonal loss, the brain atrophy, and the progression of disability. So we need to impact in the disease very early on, after the first event, and sometimes before. The earlier we treat and the earlier we intervene, the better the outcomes are in multiple sclerosis. But as you remember, it's never too late. So we can make an impact in the disease even after 20, 30 years of the disease. So most patients will have what we call a relapsing remitting multiple sclerosis, and some patients, like the orange here in this cartoon, have what we call primary progressive MS. Are those different disorders? Probably not. Are different presentation of the same disorders? Yes. Patients with primary progressive MS probably didn't have that lesion that causes symptoms that we call them relapses. But the disease process itself is very, very similar. Those are the symptoms that patients may have, and probably you are all experts on this: sensory, visual, balance problems, motor problems. That's just the pathology of MS, trying to show you that there are many phases of the disease. We have inflammation happening, that immune interaction to the cells, to the brain cells, and that inflammation, the brain will try to repair and recover the damage. And that's that yellow triangle that we have here, regeneration. And we all have natural mechanisms to repair the brain. And what we are trying to do with the medications is stop inflammation and allow the brain to repair by natural mechanisms. I have 1 minute. And then the blue triangle is this brain atrophy or degeneration. So what I'll do, I'll show you this wonderful cartoon that will be a nice segue for Dr. Bolmer's talk about how to treat and how to enhance brain health, which is what we know is happening. So the upper section of the slide is the blood vessel. The lower section is actually inside the brain. And you see that the cells, the T cells and the B cells, are trying to get inside the brain through that blood-brain barrier. And once they get inside, they're going to recognize those brain cells, the myelin around the brain, the axons and in the brain cells, and they're going to destroy that, causing the plaques, the MS lesions. When you do an MRI, you see those white dots in the brain. Those are areas of demyelination. So what we are trying to do with our therapies is stopping this immune interaction to the brain. And talking about stopping, I'm going to stop right here. And I will be around to answer questions. I believe we have some time at the end to answer questions. So thank you very much for your attention.
Thank you, Dr. Miravalle. Just a reminder that you guys have cards. We've gotten some questions. Keep them coming. You can write cards on both sides if you need to. I would now like to welcome Dr. Timothy Vollmer, Medical Director of the Rocky Mountain MS Center, and his talk on maximizing brain health.
So thank you all very much for coming out this Saturday. This audience is actually very representative of what MS is. So the audience contains healthcare providers, and it includes teachers, professionals, business people, people from all walks of life. And my purpose today is actually not so much to simply review all the anatomy and pathology and other things that goes into MS, but actually to ask you to help us change the way that the world treats patients with multiple sclerosis. And what I'm going to be arguing is that it doesn't matter what stage of MS you're at. The goal of therapy should be to maximize your brain health for the rest of your life. It doesn't matter when we start. That should be the therapeutic goal. And my point is that, by and large, the world discriminates against MS patients that are older, that may have progressive forms of the disease, may have started out with progressive forms of the disease, and they do that for the wrong reasons. Many physicians around the world actually believe that MS is multiple diseases rolled into one diagnosis. However, the data says that that's not the case, that it's actually, by and large, a single disease, has a single set of pathological pivot points that are critical to the disease, and that with appropriate management, we can have a major impact on the disease course in almost everybody with multiple sclerosis. So this concept of maximizing lifelong brain health is to both emphasize that we want to treat early to prevent damage, and we want to help patients adopt lifestyles that actually enhance brain health and allow the brain to compensate for injury more effectively. So I'm going to be talking about a concept called brain reserve, and I'm going to try to explain to you a little bit about how that actually explains the different clinical patterns that we see in multiple sclerosis. And I'm going to try to lay a foundation to argue that we're discriminating against patients for the wrong reason when we give them these labels and we deny access to therapies. Also, I'm going to argue that the issues that most of the world or the data that most of the world is using to deny access to newer, more effective therapies for MS patients is based on one or two small papers. And I would argue that that's inappropriate, that if you look at the body of literature, all the papers, you would come to the same conclusion that I've come to. So the first thing is, the primary topics we're going to talk about relapse remitting and progressive forms of MS are the same disease. I'm going to talk about brain volume is related to brain and cognitive reserve capacity. And by reserve capacity, as Augusto mentioned, we mean the capacity of the brain to compensate for injury. So this is the issue for football players, for soccer kids. This is worrying about early life trauma. That is hidden because the brain can adapt for it, but it comes back and haunts people later in life because it accelerates cognitive dysfunction. I'm going to talk about that the onset of progressive MS actually represents the point where the brain has used up most of that brain reserve capacity and is simply unmasking what's been going on from the very beginning. That the onset of progressive MS does not represent a fundamental change in the disease. It simply changes the lens that we're looking through to see what's going on in the disease activity. And I'm going to argue because of these things that our key therapeutic goal in MS is to preserve brain volume in early MS. So these are the different patterns of disease that Dr. Miravalle introduced to you. So at the top, I'm going to use the arrows here. So the top three, or the top two cases are relapse remitting patients that go on to have a secondary progressive course. C and D here are patients with primary progressive disease. And this points out that some patients start out with primary progressive disease, go on to have relapse. In fact, a third of such patients will. And then you have these other forms down here where people have relapses early in life. They may go for years without relapses just to enter the progressive phase of the disease. These last two cases here that might fit what we call benign MS, and, but I would say these are actually quite rare patients. We don't really see this very much. However, the perception of this around the world is variable. In Ottawa, they assume that about 40 to 50% of patients have benign MS, and they don't treat that 40 to 50%. However, the data would say that this is less than 5% over a lifetime. Now, the key thing that the field keeps forgetting is that there's a fundamental difference between these groups of patients. The patients that are starting out with relapse-remitting disease have a mean age of around age 30 at onset. The patients who start out with primary progressive forms of the disease have a mean age in the mid-40s, 45 to 47. And the patients who have secondary progressive onset also have the same age as the primary progressive patients, age 45 to 47. So I would argue that the differences that we've seen in clinical trials is related mostly to this age effect and not to this classification system, whether relapse remitting or secondary progressive or primary progressive. And the reason for that is that the inflammatory attack on the brain is decreasing as a function of age. The immune system is changing. So most of the inflammation, as Dr. Mervalli pointed out, is occurring at first onset of the disease in the 20s and 30s, and it steadily decreases thereafter, and I'll show you some data for that. So I'm not going to go into this data in detail. I'm just going to point out that the data is there. The scientific literature has the information that I'm going to give you. So the first thing is that there's been a lot of studies published saying that relapsing forms and progressive forms have different genes associated with them. That isn't true. All those studies that report that are small studies. This is a list of large studies. Some of these included over 10,000 patients. They should have been able to see if there was a genetic difference between the progressive and relapsing forms of the disease, and none of these papers, even though they're the largest papers in the literature, were able to demonstrate that. Dr. Ebers, epidemiologist in MS, reported a decade ago that if he looked in families that had multiple affected individuals and asked what was the probability that a member of that family would have primary progressive disease, it was 10 to 15%, exactly the same as it is for the overall population. So it doesn't matter what your early life experience is, your genes are, your environment, the risk of having primary progressive disease is the same. And then in terms of pathology, again, there are a lot of papers reporting pathological differences, but again, they're small papers with small numbers of subjects. And this is two review papers that were requested by a journal called Multiple Sclerosis Journal. And these two authors were asked to have counterpoint opinions. One was asked to argue that the pathology was the same, the other was asked to argue that pathology was different. And they're both very prominent neuropathologists in the world and do a lot of work in MS, Dr. Lossman and Dr. Coleman. But they both ended up arguing the same thing. No pathologist can look through the microscope and tell whether that brain section came from a patient with progressive disease or relapsing disease. There are 37 peer-reviewed papers in the literature reporting that there are immunological differences between relapsing remitting patients and progressive forms. And they all suffer from two problems. One is they don't control for age. And I just told you the immune system is changing as a function of age. And so if you don't control for age, the fact that you see differences is more likely due to age than it is to the classification system that they used. But the second, and from a scientific standpoint, the most damning comment about these papers is not a single one identifies the same factor as the other papers do. So there's no confirmed immunological difference between progressive forms and relapsing forms in all the literature that's been published. And despite this, most of the world thinks that progressive patients have moved out of the inflammatory phase of the disease and are now in a separate neurodegenerative phase, that the inflammation has set off a separate process that becomes independent of the inflammation. There is no human data to support that. In fact, the human data says that that's not true, that damage to the nervous system is directly related to inflammation, and when the inflammation goes away, so does the accelerated damage to the nervous system. And I'll show you some data for that. Sure. So most of the world right now thinks that when patients become progressive, that the form of MS has changed from the inflammatory form that we see when we do MRIs and we see those gadolinium-enhancing lesions or relapses, and that it's moved into a neurodegenerative disease, much like Alzheimer's or Parkinson's disease, where the loss of neurons and the loss of brain substance is independent of the inflammation. And that's the reason they deny access to anti-inflammatory therapies for patients with progressive disease. What I'm saying is that the science behind this says that that's not the case, that there's a direct relationship between damage to the nervous system and the inflammation, and when you shut off the inflammation, that also stops the damage to the nervous system. This is looking at the MRIs. Many of our colleagues outside of the Rocky Mountain MS Center would argue that MRI patterns in patients with primary progressive disease really look different than they do in relapsing forms of the disease. However, those papers have several compounding factors to them. But if you actually look at the results of this, remember this relapsing patients here on average 15 years younger than the patients in either primary progressive or secondary progressive. And if you look at the differences here, this difference in inflammation is explained simply by age. And in fact, if you control for age, this difference goes away, and primary progressive patients look exactly the same as relapsing patients in terms of MRI parameters. And all these other markers of MRI changes that we look at, the difference between the relapsing patients and the progressive patients is simply in magnitude. It's not a qualitative difference, it's a quantitative difference. But again, these patients have had disease for 10 to 15 years longer than these patients. So you would expect that. That's a logical expectation for this. And yet this data is used oftentimes, again, to deny access to inflammatory therapies, anti-inflammatory therapies for progressive patients. So if they're the same disease, then my colleagues would point out, well, why do they respond so differently when we do clinical trials of these therapies in the progressive forms of the disease? And so I'm going to go through that. So there's several things. First is, that, as I said before, that the inflammatory phase of the disease is decreasing as a function of age. That's reflected in a decrease in relapse rates as a function of age. Relapse rates, as Dr. Miravalli pointed out to you, is only the tip of the iceberg. In fact, it represents 5 to 10% of the total inflammatory attacks that are occurring in the nervous system. For example, if you do monthly MRIs, we will see 10 to 15 new MRI lesions for every clinical relapse. So most of the inflammatory disease is subclinical, but it is damaging the brain, and as he pointed out, the brain is shrinking as a result of that damage. If you look at the clinical factors that have the strongest predictive value in terms of identifying where somebody is going to be progressive or relapsing, the actual strongest factors are age and the magnitude of brain atrophy. And again, age correlates very strongly with the classification system of whether you're relapse-remitting or secondary progressive. So it explains what we see there very well. Also, the brain atrophy is not a late complication. It's occurring right at the very beginning of the disease, but it's clinically inapparent because the brain has reserve capacity. It can mask that. One of the key experiments that needs to be done to try to convince the world of this is to look at the rate of brain atrophy as a function of age. And it's despite the fact that we have tens of thousands of patients who have gone through MRI studies and we have that data, no one's ever analyzed it that way. So we're in the process right now working with a couple of companies to look at their placebo arms to ask that question, but we did a meta-analysis of all of the published papers on phase 3 trials, and when you stratify those studies based on the mean age of the patients in the study, the patients with the youngest age have the most rapid rate of brain volume loss. And so if we can just get this other paper out, I think we can prove that to people that there's a direct relationship and that brain atrophy is not actually a late complication, it's an early complication. Also, MS continues to be described as a disease of the white matter. It is not. It's a disease of the entire central nervous system. The gray matter is just as attacked as the white matter, but it's invisible in terms of a lot of the standard techniques we use to characterize MS, either pathology or imaging, and that's for technical reasons. But we know that the gray matter is attacked early in the disease, and I'm not going to go through all the data, but the rate of that attack in early disease actually has the strongest predictive value for late life outcomes. So if most of the disease going on in MS patients is subclinical, then one has to ask the question, how can it be subclinical? Well, the only way it can be subclinical is that the brain is adapting. It's using its reserve capacity to mask that. If you admit that, then you have to ask the question, is the reserve capacity of the brain infinite or is it finite? Nothing's infinite, so most likely it's finite. And if it's finite, then you have to ask the question, what happens when you run out of that brain reserve? And that's a question that the field has not asked. And as a result, they have not tumbled to the reality of what we're actually doing to patients. So this is some evidence showing that the relapse rates are decreasing as a function of age. This is disease duration, this is age. And you can see patients in the 20 to 30 years of age have the highest relapse rate, and it drops off by 60 to 70% by the time patients reach 60 years of age. If you multiply these axes by 10, that would be the number of MRI lesions that you would see on average in these patients, and you see exactly the same pattern. Brain atrophy is a more recent way that we characterize what's going on in the brain of MS patients, and it's evolved out of newer MRI techniques that allow us to calculate the volume of brain very accurately. And so we know that in healthy age-matched controls that the brain peaks in volume in the late 20s, early 30s. And then, in all of us, it will gradually decrease in volume over life. Our ability to compensate for that loss of neurons is related to how much brain reserve we have. And that's why maximizing brain health in early life for all of us is going to be important for us when we're in later life in terms of how long we can go into our 70s, 80s, and 90s and maintain relatively normal neurological function. However, when we looked at, this is data from a paper that we've been working on, when we look at the average rate of change in MS patients compared to age-matched controls, it's 6 times greater in MS patients than it is in healthy controls. And that doesn't matter whether you're on interferon, Copaxone, or placebo. It's the same in all 3 of those groups. Brain atrophy is present at the very first presentation. When patients have their first event and they come in, if you do brain MRI volumetrics and you compare them to age-matched controls, they're already more than 2 standard deviations below the mean. And as I mentioned before, brain atrophy is the strongest predictor of later life outcomes. This is some evidence looking at a number of papers at the rate of brain atrophy in different forms of the disease. And this is clinical isolated syndrome. These are patients who had their very first attack. These are patients who had at least 2 attacks or more. These are patients with secondary progressive, and these patients with primary progressive. What you see here, there is no increasing in rate. Sorry, this keeps flipping. There's no increased rate in brain volume loss as a function of the disease form. And remember, the patients out here are 10 to 15 years older than patients back here. This is directly contradicting the view that MS is 2 diseases, first an inflammatory disease, and then secondly, later on, a degenerative disease. This is not true. It's simply the same disease all the way through. This is just correlation coefficients looking at predictive value for the different components of the nervous system in terms of predicting disability. So we're looking, I'm sorry, this computer set up to advance when I touched that pad as well. We need to change that. So anyways, this is looking at just gray matter. So with the MRI, we can actually separate your brain into 2 compartments. We actually separate in a lot of different compartments. But we can look at just the volume of gray matter that you have and just the volume of white matter you have. And when you look at the predictive value for different forms of disability, such as walking, this is a combined measure of upper extremity function, which is a 9-hole peg test, a timed 25-foot walk, and a cognitive test called the PACE-AP, a very painful test. Anyways, what you can see, these R values, the higher they get, the closer they get to 1, the more strongly they predict disability progression. And damn this thing. Sorry for that. And you look down here in the white matter fractions, the numbers are very small, 0.03, 0.16. So they're a third or less the predictive value of gray matter. This is why the field has got to stop focusing on white matter lesions and begin to focus on gray matter injury, because it's the gray matter injury that impacts patients and limits their ability to function. This is looking at the predictive value of brain atrophy rates to predict disability 6 years later. So this was a study in patients that were in the AVONIX trials, and Beth Fisher and the group at Cleveland had studied the patients over 2 years in the pivotal trial, and then they took those patients, 138 of them, and they put them into 4 groups. The first group here, if I can get the mark. The first group are the patients that have the least brain volume change over those 2 years, and the fourth group were the patients who had the most brain volume change. So this is just 25% of the patients here, 25% here, 25% here, and 25% here. Then they follow those patients for another 6 years, so over a total of 8 years. And they asked what was the probability that a person would have enough increase in disability that they would have to use at least a cane to get around. And what you can see is that if you were in the most rapidly progressive group in terms of brain volume loss, you had a 4-fold higher risk of reaching that endpoint in the 8 years of this observation. That's a substantial risk. Most of the time in medicine, we're treating relative risks about 1.2 to 1.3. This is a 4-fold risk. This is a big effect. Now, this is a functional MRI study, and functional MRIs are just another way of looking at the brain with MRI, and it allows you to see the parts of the brain that are active when the person is doing a task. And in this particular task, both these individuals are being asked to tap a rhythm with their dominant hand. So they're in the MRI unit and just simply tapping a rhythm with their finger. And this patient is a patient who had their very first clinical attack, a young woman, and this affected her right upper extremity. So she has some sensory loss and some dexterity loss in her right hand. At this point, she's now recovered from that relapse, and her neurological exam is essentially normal. Compared to an age-matched control, she's tapping in the MRI, and what you can see is that the colored area here are the parts of her brain that are activating, allowing her to tap that rhythm. And what we're looking at is oxygen consumption. So these brains are, this is the area of the cortex that's active. She's using, she's using more cortex than the healthy controls, and she's using more supplementary cortex. That's the cortical remodeling, or the rewiring capability of the brain, the reorganization that the brain has. That's reserve. So the more reserve you have, the more that you can do that. When you run out of reserve, you run out of the neurons that you can recruit into these tasks, and as a result, that limits your ability to recover. This concept of brain reserve and cognitive reserve actually comes out of the Alzheimer's literature. And this is a paper from Dr. Stern back in 2009 that sort of summarizes the hypothesis. But the point here is that we have 2 different lines. The blue line, the top line, are patients that are ultimately going to develop Alzheimer's disease, and they have higher levels of education. They have college degrees or above. The yellow line are patients who are going to develop Alzheimer's disease, but they have a high school education or less. And what this shows is that if you have more education, you guys, it's the technical people to shut this thing off. You need to make this dumb for people like me. So if you have more education, it takes you longer before you begin to develop symptoms of cognitive dysfunction. And once you develop those symptoms, you will progress just like the other patients at a slightly higher rate and eventually catch up with them. But this difference, this delay in the onset of the symptoms, that's the reserve function that patients have developed. And what this is pointing out is that your brain reserve isn't simply what you're born with, it's also what you generate by living a healthy, active lifestyle. So if you're studying, you're learning languages, you're practicing new skills, you have hobbies, you go to school, you go to church, you volunteer, any of those activities help your brain make new connections between the nerve cells that you've got. And the more connections you have between your nerve cells, the more flexibility the brain has in shifting function around if you have a problem. And so this is what we talk about. What we mean when we're saying maximize brain health over a lifetime is helping people adopt the habits and the activities that actually increase their brain reserve and allows their brain to compensate for the MS more effectively. These are some of the mechanisms behind it. It just points out there's lots of factors that determine how much brain reserve you have. So we have genetics, we have in utero health, we have early life activity and nutrition and diseases. Some things will decrease your brain reserve, other things will increase it. So education, physically active lifestyle increases it. Playing NFL football decreases it. And these are the sum totals of things that we have to deal with as we go through life. This is just demonstrating that it's true in MS. This is a recent paper from James Simnowski and the group in New Jersey. And what they're looking at here is the cognitive performance of patients on a battery of tests as a function of brain volume size. And the bottom line is, the bigger your brain, on average, the better you do in these cognitive tests. There's a lot of variability, but still there's a positive trend with a fairly high R value, about 0.4. Also, they showed that people who were more active also were able to have better cognitive performance, so increasing leisure activities of all sorts. Just having an active lifestyle improves your brain ability to perform cognitively. In terms of MS, having a larger brain volume allowed patients with MS to compensate for increasing T2 lesions, which are the white spots we look on your MRI, for them better than patients who have smaller brain volumes. But also, patients who had a more leisure activity, were studying, learning, staying active, they also were better able to compensate for increasing lesion load on their MRI versus patients that were less active. So again, this is direct evidence that brain reserve and cognitive reserve referring to that active part of it, are applicable to MS as well. So if you summarize all of that, as Augusto said, there's a lot of disease activity that is subclinical. That's what I'm trying to represent here. Relapses are about a 10-to-1 ratio to that MRI disease activity. And these relapses and this inflammatory activity are causing the brain to shrink. And that's this line down here. And so what I'm arguing is that the relapsing phase of the disease, people look like they're stable between relapses, but they're really not. The brain is changing. But they look stable because they're using reserve function to compensate. But that reserve function is decreasing over time. And when they run out of it, that's when they enter the progressive phase of the disease. It's not a change in immunology. It's not a change in the neurobiology. It's simply that the brain now can no longer mask what you're seeing going on underneath. That now becomes apparent. And all the subclinical disease activity becomes apparent as slow loss. Now, this progressive phase of the disease is not just due to inflammation in MS. It's now also due to normal aging, because we're blocking the normal aging effects that are occurring in the brain because we have brain reserve. And if you use up the brain reserve in MS, you don't have it available to age normally. So patients that are in this phase will notice that even if we shut off the disease with highly effective therapies, they'll notice they're still slowly getting worse, much slower than they were before we treated them. And that slow worsening is just normal aging that occurs in all of us, but it's unmasked by the use of the cognitive reserve and brain reserve for the MS. So our approach at the Rocky Mountain MS Center to trying to manage this is to treat as early as possible with therapies that have the most effect on preserving brain volume in order to maximize lifelong brain health in MS patients, and also help patients adopt healthy, active lifestyles, and to avoid other illnesses that would put similar stresses on the nervous system. And I would argue that our strategy is important because we're dealing with the cost of the disease from a slightly different perspective. So there right now are activities or moves going on in the United States that may end up limiting access to particularly the newer therapies for MS patients based on the perception that they don't work in patients that are older or have progressive forms of the disease, which isn't true. And it's because of this cost here. This is the cost of the drugs that we use. And this is a study out of Europe. It's the same in the US. Basically, it's pointing out that about 10% of the overall lifetime health costs of MS are drugs. About 5% are the physician's visits and office visits. These four areas here are about 70% of the total cost. And this blue area down here, this is disability payments, being on sick leave, early retirement. This area over here, this 28%, this is healthcare services such as physical therapy, occupational therapy, speech therapy, visiting nurses. And this 10% up here, this is hospitalization. What we would argue as a team here, and we all have the same view, is that if we use these costs here more effectively by applying these costs to the most effective therapies that we currently have, particularly at first diagnosis, we could have a dramatic effect on decreasing these costs here. And this is the problem that in the United States, the health insurance companies don't deal with these costs out here. They deal with some of these, but they don't deal with most of them. They deal with this cost here. They're all focused here. And so we actually get pushback even when we go to argue with them that if we use more effective therapies here, we would decrease this cost. They would say, well, we don't pay for that. We don't care about that. We care about the direct costs right here. That has to change. Medicaid in particular should be sensitive to this, and Medicaid right now requires patients to be on interferons and Copaxone and fail those before they can go to any of the newer agents, even though we have good comparative data, head-to-head trials showing that the newer therapies are more effective, and they can be used just as safely as the older therapies. This is comparing the drugs in a different way. Usually we compare drugs based on their reduction of relapses and their effect on gadolinium enhancing or new lesion formation on MRI. Those two measures are really not very important because they don't predict the outcome in MS very accurately. These two measures do. So the first area here is decrease in disability progression. This is a definition where we're calculating the percentage of the population in the study that worsened by 1 point on the scale that we use, and they stayed worse by at least that 1 point for 3 months or longer. And then the other one is brain atrophy. And the point here is that if you compare the newer agents up here, they're significantly more effective, particularly on brain atrophy, than the older agents are. And this difference up here explains the different outcome that we see in patients in our clinic who are on more effective therapies. This is an example. This is from 2010, a large international meeting on MS, the largest meeting in the world on MS, called ECTRIMS. And in 2010, Copaxone had been out for about 4 years. And centers around the world had studied populations of patients looking at different outcomes, fatigue, upper extremity function, walking, employability. And what they reported was that if you take a group of MS patients, 50 to 100 to 200 patients, and you put them on, in this case, Tysabri, and you follow them for 1 to 2 years, on average, that patient population is getting better, not getting worse. They're getting better. Not everybody in the group gets better, but the average scores are, which means the majority of them are. We do not see that with interferons and Copaxone, unfortunately. This is a fundamentally different observation that we've never seen before. And this is a newer concept. I'm afraid the format's been changed a little bit here, but this is using a concept called NEDA, no evidence of disease activity. It's a definition that we're pushing to have used in clinical trials more as a primary outcome measure. What it means is that we're looking at the percent of patients during the study that did not have a relapse, they had no worsening of the progressive disability, they had no changes on their MRI. And actually, there's a NEDA 4 that I think is the most appropriate one that also includes that their brain atrophy rates are in the normal range. And what you can see here is that depending on what study you look at, there are differences in the likelihood that a patient will meet that definition, no evidence of disease activity by the end of 2 years. In the AFFIRM trial, which was the Tysabri trial, patients in the active treatment arm were 5 times more likely to meet that definition than patients who were in the placebo arm. Now, these numbers are complicated because in fingolimod, which is Gilenya down here, this was only a 1-year study. And the probability of remaining in NEDA actually increases the longer you're on drugs. So you can't take this absolutely literally. But it is possible for experts to compare this and to think about this data. And if you look for convergence of data, so you don't pick out just one outcome from a study, but you look at all the outcomes in the study, you can rank these drugs based on those that have more evidence of higher efficacy than those that have lower efficacy. And that's what we're arguing, is that the field has got to be more inclusive at looking at multiple outcomes and seeing, are they concording with each other? Are they coming together? And the fact is, if you look at patients on natalizumab, they have a substantial probability of improving. They have very low relapse rates, and the brain volume rates have decreased by 45% over the 2 years of the study. So again, progressive MS is related to more than just the MS activity. It's also related to disuse activity. So as you become more disabled, you're not able to be quite as active. That means you're going to lose muscle mass at a little bit higher rate. But it's also age, and I would argue age is the major effect. We've actually seen that in clinical trials. This is from Alistair Coles with alemtuzumab. And these are, the orange is the relapsing patients, the pink here is secondary progressive patients. And what he shows is that if you take relapsing patients and you treat them with alemtuzumab, which is a newer therapy I think Dr. Corbett will talk about, they actually get better in the first 6 months. This is I'm trying to get the arrows because we can't use two screens here. So what you see here is that in the first 6 months, they actually get better. They improve by 2 points on this scale, which is a big effect. And they continue to improve out to 3 years. The secondary progressive patients, though, did significantly decrease the rate at which they're getting worse, but they're still slowly getting worse. And I would argue this worsening here is age. And what that means is that if we're going to treat that, we need to treat it by healthy lifestyle, keeping patients active, having them maintain a good healthy diet, et cetera. We don't yet have a cure for age, but we're working on it. So, and here I just point out that if you, the reason that diet is important is not so much because it treats the MS, but because it prevents other health problems. And this is just pointing out if you develop other health problems, such as hypertension or vascular disease, obesity, overweight, or diabetes, that they significantly increase your odds of being disabled. So we do really want to maximize health by minimizing illnesses that result from other comorbidities. And this just points out, again, if you have high blood pressure and diabetes, your rates continue to go up. So the more diagnoses you have, the worse the outcomes. Benefits of exercise, it improves everything. And this is a study we did earlier that if you look at patients that are active, they have substantially less disability in all domains than patients who are not active. So again, I would argue that we really do need to think long-term in MS patients at any time that we're seeing them. So this means when we start, we need to imagine where they're going to be at the end of life. And we need to treat them to optimize that course as much as we possibly can. And we actually have tools in the clinic right now that if we were able to use them the way that we think they should be used, we could decrease the risk of disability progression in newly diagnosed patients by over 70%. What I'm saying is that we could take a newly diagnosed patient and have so 70% of those do not develop significant disability over their lifetime. We already have those tools. But we're prevented from using them in the right way by third-party payers, by the government, and in the rest of the world by their centralized healthcare systems. So we really need you as family members, as patients, to understand this data and help advocate with us. Get the National MS Society, the Rockman MS Center, MSAA, Can Do MS, all of us to get together to argue that we have the data, we can use these drugs better, we can improve the outcomes. We need to get the regulators to look at this in a new way. Thank you very much.
Welcome back. I hope that everyone's enjoying their morning so far. We did want to take a moment out just to say a sincere thank you to all of our vendors who have supported us and joined us today and encourage you during the breaks. Yes, round of applause for them. Thank you. We couldn't do this without their support. And I'll turn it back over to Michelle now for our next introduction.
Thank you. Many of you were asking about your questions that we didn't get to, and we are going to do a question and answer posting, not of all the questions, with the docs on our website in a couple of weeks. It is now my pleasure to introduce Dr. Enrique Alvarez, an MS specialty neurologist from the University of Colorado, who is speaking about the overview of symptom management.
Hi. All right, so be talking a little bit about symptom management, and just the first part that I usually like to kind of talk a little bit about is where do symptoms kind of come from. Lesions of the brain tend to affect different parts of the brain, and depending on where those lesions are, that's kind of the symptoms you tend to sometimes get. And so I guess maybe if we start looking at some general idea as to different parts of the brain control different parts of what we do. This is a little bit more like the map that we tend to kind of see a little bit. And so there's different parts of the brain that help us control different things. If we look at sort of the part that actually does most of the sensation and motor, it's a really small part of the brain. And that's a lot of times why sometimes you can have lesions and not have symptoms. So the map that we tend to still look at a little bit more gets a little bit more complicated. And it's kind of the way I think about it a little bit sometimes is as an interstate system. So it's not so much kind of where things are at in that brain, but what's everything that's traveling through those areas. And the different colors here are showing connections between nerve cells. And the colors just represent what direction that's going. But you can see that the areas where lesions tend to happen, which is usually where these tracks are at, can really sort of affect things that are in very different areas than that. So sometimes to kind of simplify it, it looks a little bit more like this, where you have sort of a big interstate system, and lesions can sometimes happen in the middle of nowhere and not hit a road. Sometimes they can happen on a small road, or sometimes they may happen at a big intersection and really disrupt things a lot. It's a little bit about sort of location, location, location. Size has something to kind of look at that as well. But the issue of many of the lesions are clinically silent. And so why is that? Again, and that just depends on where those lesions are at. There can be a huge disconnect. We can see patients who have a ton of lesions, and when we see them in clinic look really good, and patients that look really bad and only have a few lesions. And so that's where we tend to then start looking at other things. MRIs, for example, can help us a lot and sort of help guide that process. So about 90% of these lesions can be clinically silent. The way I kind of think about sometimes this process a little bit is that these lesions are kind of like potholes on that interstate system. So there's a lot of fiber tracts here and a spinal cord lesion that are kind of going up and down. And sometimes that lesion doesn't look very big, but it can give you a lot of stuff. So it's not just location, but how much damage that lesion is causing to the underlying tissue. The way I think about MS lesions a little bit is sort of like bruises. So the analogy I tend to use for my patients in the audience, you've probably heard this before, is if I punch you really hard in the arm, things tend to kind of, not so much, they don't look that bad initially, but they kind of gradually build up. There's swelling that happens. It takes sometimes a day to kind of see that. And then you start getting all these color changes. You may end up with some scarring at the end of that. And the symptoms should kind of follow some of these sort of basic guidelines. Bruises can change. Sometimes you get things that pop up pretty fast and go away pretty fast. And it's the same thing with MS lesions. The other thing that you see then is the scarring. So it may not have active inflammation, but that may not look and do very well, and that's going to be very bothersome. So sometimes you can have symptoms without having a lot of the new lesions or new bruises, but just those old bruises some days are going to affect you more and give you more symptoms than other days. So we talk about MS relapses as sort of these inflammation events, these bruises that happen in your brain. And then we talk about MS symptoms and kind of the resulting effects from that. But you can have sometimes symptoms that are related to relapses and things that sometimes are not related to relapses. And so sometimes we talk about these things as being pseudo-relapses. And I think this is a useful concept because it helps us really try to set the stage a little bit for when you have symptoms that are getting worse or new symptoms, are we dealing with things that are related to inflammation that we can do something about with things like steroids or things like this that where we want to intervene? Or are we looking at things that they're related to the scarring, and at this point that damage is done, and we need to kind of figure out ways to kind of try to make those symptoms be better. And the steroids at this point may help because they may give you some energy, but they're not really going to help change sort of long-term what that is, and you start getting sort of the side effects of steroids in the long term. So sometimes, basically, you can have that same pothole very well lined up on a clear, sunny day. You see that pothole, you change lanes, and nothing, you don't even remember seeing that pothole a few days later or just even a few minutes later, right? But that same pothole, if all of a sudden it's covered with rain and there's lots of traffic, it's under a blizzard, it's nighttime conditions, whatever, you hit it and you hit it hard, and that pothole hasn't changed. But how you interact with it is very different from day to day. And so those symptoms that you have good days and bad days, basically what we're seeing are these kinds of changes. All right, so let's talk a little bit about what the different symptoms are. So what are the initial symptoms that sometimes help us point in a direction towards what relapses are, what's associated with bruising, or what are the things that we tend to kind of think of, if I see this, I'm more worried that there might be one of the relapses. So these are kind of initial symptoms. You can see that this is data from 1972, so some of these changes are probably different now just with the use of MRI, because before MRIs, we wouldn't tend to associate things like fatigue or tingling or things like this. Patients wouldn't go to their doctor for these kinds of symptoms because the reality is we wouldn't know what to do with it, and sometimes we still don't. But it helps us to try and get an idea, sort of a list of symptoms that we can kind of look at. So you can see that weakness, problems with vision, that can be decreased vision, double vision, sort of problems with dizziness, and particularly dizziness to us is kind of like a very generic term. It can mean lightheadedness, like you're going to pass out, vertigo, which is kind of more of a room spinning sensation. So we don't tend to think of lightheadedness much as an MS symptom, but vertigo is something that we get worried about. It can also be an inner ear thing. So these are the things that we tend to ask so many questions and annoy you in clinic when we're asking so many different details about how things started, how long they lasted, what those symptoms look like. So as far as then when symptoms are kind of more persistent, which is kind of the main focus of what I'll be telling you about, is to talk a little bit about what are the symptoms and how do we target those symptoms. But it's important because you can end up with a lot of symptoms and end up on a lot of different drugs with a lot of different side effects that make other symptoms worse. And it becomes a downward spiral sometimes. And so I think you have to kind of have some criteria to kind of say, is it worth intervening or not? Can we do enough about it to make it worthwhile take a medicine? And so these are the kind of questions I think that a lot of times are worth trying to look at in clinic. And for you to have thought a little bit about when you're coming in for us to be able to kind of talk about what are the priority of list of symptoms, because we really want to sort of kind of focus on one or two things because there's so many different things that can affect each one symptom. And a lot of times they're very intertwined. So we have to look at sort of, we definitely want to minimize discomfort. That's the goal of things. We want to be able to improve function. We want to be able to limit the side effects of these drugs. So a lot of times that's what's the smallest dose of a drug that we can use in order to minimize those symptoms without getting into the side effects. And I think a lot of times it's sort of setting realistic expectations. A lot of the drugs that we have for these kinds of things aren't 100%. And can we really, if we reduce something to make it kind of a tolerable pain level, for example, is that okay? We could always put you in a coma and take care of all pain, but that's probably not a good quality of life. So as far as kind of common symptoms and different things, you can see that there's a big list, and some patients will have all these different things. And so trying to approach all these different things in clinics make it very difficult. I will try to touch base on a lot of these different things kind of briefly today. But it's recognizing that a lot of these things are very intertwined with each other. So if you have a lot of depression and fatigue, you're not going to exercise as much because it's hard to kind of get out and do things when you're not feeling well. That might make constipation worse. It might increase the tone in your muscles. That might increase sort of bladder problems, which then is going to, if you're waking up in the middle of the night, not let you sleep. And then if you're not sleeping, you're going to be tired, and so you're not going to be able to concentrate, and that's going to make you more depressed. And you can see where it becomes a downward spiral. And it's important to then try to figure out and tease out all these details to try and figure out where are the parts that we can sort of have the biggest effect on to try and get that upward spiral going. So we look at MS symptom management. It involves a lot of different things: patient education, physical activities, kind of specialist, and prescription medication. So sometimes there are things that we feel very comfortable doing, but I would not feel comfortable, for example, having to do Botox in bladders or something like this. So there's people that are much better at doing certain things, and so we work sort of as a team. And there's a lot of specialists that we interact with, a lot of physical therapists, neuropsych colleagues, the radiologists that look at MRIs. We get very good at looking at MS brains, but sometimes there are things that just don't look quite right, and so talking to people who have much more experience with other things is very useful. Patient education, that's why you're here today, is trying to kind of improve sort of that dialogue so that we can have a bigger effect on things. And physical activities, the maximizing brain health that we talked a little bit earlier is very important. So what are the most common symptoms? So fatigue, so that's kind of the one I kind of starting. This is a huge, very common symptom for most MS patients. Probably about 75% of patients will report fatigue. Anybody who has little kids, that's 100% probably. And if you get both, it's not helpful, right? But it's important to kind of start looking at sort of those other things that might be able to affect fatigue besides sometimes just MS. It may be the presenting symptom in up to maybe a third of patients. Patients may have a lot of fatigue and it's kind of nonspecific. Would you necessarily be getting a brain MRI to start evaluating for fatigue in everybody? If that's the case, probably everybody, you just have to line them up, everybody through the MRI scanners because it's such a common symptom in the population. So that makes it really hard sometimes. And as many of you might know, it may explain why there's such a delay sometimes in diagnosing MS. So you have to kind of look for things that sometimes make sense to the image. If things don't make sense, to kind of look at those things. And almost probably close to half of patients will say that this is their worst symptom. So trying to figure out sort of fatigue and try to break it down, I think, is very important. When you have a lot of damage in the nervous system, it takes extra energy to get things done. You don't compensate as well. So to go back to the pothole analogy, if you're having to constantly swerve lanes, it's a lot harder than if you can just put it on cruise control and just go, right? And so if you're having to kind of do a lot of stuff like that during the day, by the end of the day, you're wiped and you're done. And so it's very important to kind of try to figure out ways to minimize that. What's kind of setting up realistic expectations. What can I really do in a day? Can I work a 12-hour day? Well, maybe that's not realistic, whether you have MS or not. But it's trying to understand for you, what's that limit that you can do? If you're out of shape and you're not exercising, right, that energy level is not going to, the energy level is going to be lower. So it's important to kind of do that physical activity, kind of get strong, build up that stamina so that you can kind of build up to that. This is the double-edged sword, right? So if you work out, then you get more tired, you wore out, you poop out sooner. So how much can you push it? The answer is different for different people. And so it's trying to find, for you, what's the right answer to try and do that. But if you don't do it, it's going to be really hard to kind of long-term be able to kind of overcome some of these things. If you're not sleeping, and these are common issues with a lot of people, but especially in our MS patients, you got spasms that are waking you up at night, you got bladder problems, so you're waking up at night, these kinds of things. It's not useful to go and give you a stimulant in the morning. The answer is to try and give you something to sleep through the night. And it might not be a sleeping agent, it might be something to deal with your bladder. So that's why a lot of times we seem like we might be asking sort of very disconnected questions to try and get at some of these symptoms. Other things that affect this, pain, mood disorders, medications, infections. I mean, any of this kind of stuff is going to affect how you sleep, your energy level, how well you're going to do through the day. And then there's the stuff we do to you. So pretty much almost every drug we give you is going to have an effect on fatigue. And so this is kind of the issue that we run into when patients come in when 10, 12 different drugs for MS. The concern that we always have is like, what's your energy level? Because I'm not sure I'd be able to get up and walk with that much stuff. And so pain medicines, muscle relaxers, the sedatives, the sleepers that we tend to use, a lot of times will have a hangover effect in the morning. That's going to make it hard to kind of get going. Seizure medicines, some more than others. Depression medicines, antidepressants, the same way. Interferons particularly have a huge effect on fatigue on a lot of people. And so it's trying to figure out, is this a drug effect, and can we switch it out to some other way to tackle that issue with a drug that maybe is less sedating? Sometimes that's kind of what you're stuck with, but it's trying to try to optimize and reduce those side effects and try to optimize that. Alcohol, caffeine, smoking, all those things are obviously going to have an effect. Illicit drugs, cocaine, amphetamines, they may give you that little bit of a high initially, but afterwards you're going to crash and you're going to crash out hard. And so that's kind of trying to figure out, it's hard to kind of keep chasing these symptoms. So a lot of it, when we're looking at fatigue management, it's kind of the same thing as the wheels. It's trying to figure out what kind of contributes to these things, what are the things that we can intervene on. are there things that we can do that maybe don't involve drugs, but, is it an issue of trying to exercise more? Is it maybe an issue that you're trying to exercise too much and just trying to figure out, break it down into different sessions and things like this? So trying to do more energy conservation, cooling strategies, hydrating, things like that. So another symptom that's very common are bladder issues. A lot of the common theme for these things is that if the pathways involved in controlling that are very complicated, it's very easy to at some point have some part of that be affected that is going to give you symptoms. And bladder seems like a fairly easy thing for most everybody. For some of our MS patients, not so much. And the problems can be just a loose bladder, it just doesn't hold any urine, or it could be too tight of a bladder, which is a really big concern. We can see that if you're retaining urine, you can put pressure back on the kidneys, you can hurt your kidneys and cause a lot of problems. So it's very much an issue of trying to figure out. And the problem is a lot of times all the symptoms you end up with is, I just got to pee a lot. And it's hard for us to kind of separate those things. But you can see that there's a lot of parts to this. There's issues about sort of how the bladder contracts and how much it can relax to kind of get urine in. There's a valve here that has to kind of open when you want it to and shut when you want it to, and that kind of stuff. And so there's a lot of parts to this. The brain kind of controls sort of like, right now for me, for example, it'd be a very inconvenient time to have to go to the bathroom. And so if you're trying to plan trips or things like this, that brain that helps you kind of control those things are up there. And then those fibers have to make it all the way down the spinal cord and through the brain to kind of actually to the bottom of the spinal cord, where a lot of the control for that valve to help release the urine are involved. And so there's a big pathway where lesions can affect it. I'm going to skip some of these just because we started a little bit late. So there's a lot of different treatments. Some of it is medications. Sometimes it's avoiding certain drugs. Caffeine, my favorite. The concern that sometimes we see is sort of fluid moderation. So a lot of patients will start decreasing how much they drink. They don't want to have those accidents and things like this, but then you can get dehydrated and run into problems. And so it's trying to find that balance again. Things like pelvic floor exercises, time voiding, things like that can really help. And a lot of times we could try sort of the first few lines of medications, and then a lot of times we refer to urology for help. So this might be one of the specialists that we might send you out to see. Bowel symptoms, kind of very similar. This can be sort of on the constipation side, on the diarrhea side. Most of our MS patients tend to be a little bit more on the constipation side of things. Sometimes it's kind of that fluctuation. For the constipation thing, sometimes it's more fiber to add bulk. Sometimes it's less fiber. So it's just trying to figure out, again, for each person sort of what the right answer is. Exercise is a huge one, again. So if you're not exercising, if you decrease your energy level, that helps kind of push your bowels to kind of get rid of stuff. And so it's important to try and do that before we start looking at medications again. Drinking lots of water and things like this is very important. Depression is a huge issue, and this is something that I think words make it really hard for us to really kind of describe well. So if you have depression, is it anxiety, is it fibromyalgia? These things that represent very differently. There's probably something that's common to all this stuff. We can tell that, right? What's our treatment for all this stuff? Antidepressant drugs. For some of the stuff, it works a little bit better than others, but it's very important to kind of at least start to kind of understand that there's something that connects a lot of these things. And sometimes it's depression, sometimes it's a lack of energy to do things, sometimes it's irritability, and those are sort of spectrums of depression. You have anxiety, pain syndromes, other type of weird movement disorders that can sometimes happen with emotional changes, and trying to put all these things together can be very important. MS is very common. It's very common just in everybody. So there's one of the numbers I kind of usually throw out is I think it's like a third of the US population at some point or another has been on an antidepressant. It's kind of shocking. It's even higher in our MS patients, where about half of the patients have been on an antidepressant. drugs are very useful. They're the things that we're going to probably try to provide. It's not the only way to kind of deal with things. I think therapy is very useful. It might sometimes be hard to get to, hard to get it covered, hard to have the time to make it to therapy. But if we can kind of combine both strategies, I think there's a lot of benefits that you can have. And again, it's the wheels. So it's trying to find the right pieces to the puzzle to kind of be able to kind of tackle this issue so that you can help it. One of the things I always kind of talk a little bit about is that grief of being diagnosed with MS, sort of being the newer guy sort of on campus, is that I get a lot of patients that are kind of newly diagnosed. And so we kind of go through this grief response that I think is very common early in MS. And it's important to recognize that. You know, if you start looking at denial and all these other things, that's a common process. It's kind of being able to tell you that, hey, your dad just died, and being like, oh, okay. You know, that's not the way we're going to mostly respond to these things. And so it's trying to kind of be able to put all these things together again. Pain, probably one of the things that most of our MS patients, again, still have, over 50%. Pain's one of those things that I think is really hard sometimes for us to manage very well. I think the biggest issue for this is that there's different issues that happen with pain. There's different types of pain. And trying to recognize that, and recognizing that our therapies for pain aren't really good at sort of like, hey, for this kind of pain, this is the right drug. And it becomes a lot of trial and error. We have great drugs for pain, right? Narcotics work awesome. The problem is that they're not a treatment for chronic pain. They work great in the short term. If you get a gunshot wound and are having a lot of pain in the short term, that's what you need. In the long term, pain medicines are going to feed into all kinds of other issues. Constipation, the addiction potential. You start off with a little bit of an opiate, and little by little you keep adding to that dose because your body gets used to it, and then pretty soon your breathing centers get affected and things like this. Our MS patients get diagnosed early, so if you start with these medicines at the age of 10 or 20, you're going to be on these drugs for 80, 90 years, potentially. You know, average life expectancy of our MS patients is pretty similar to that of our regular population. And for women, again, 2/3 of our patients, if not higher, I think it's close to 83 years old right now. Okay? So it's a lot of years to be able to try to figure this out. So trying to figure out ways to manage things and setting up realistic expectations to what we can do and making life tolerable and not giving you a lot of side effects, I think becomes a very sort of important discussion to have. Cognitively, this is something that is sometimes very hard for us to provide a lot of input around. And we've kind of danced around the topic a lot because of the issues of we don't have great medicines or treatments for this. But we're increasingly recognizing that, you know, MS is not a white matter disease, and all that fiber track I showed you earlier is a lie. So that we are affecting sort of the processing center in MS, and so that surface of the brain. And that's where we see a lot of the cognitive issues that we have. We work a lot with sort of our colleagues, and one of the breakout sessions is with Brian Hoyt from neuropsychology here. It's important to recognize because there's a lot of sort of lifestyle changes that you can do. I always like to point out that I usually end up having 3 or 4 cards in my pockets because I forget things, and so I have to write things down. When you look at most of the residents, and especially the medical students, it just brings back sort of PTSD thoughts a little bit. But the worst image that I still have is the white coat kind of dangling like this from all the books and notes and things like this that we have to carry. So nobody expects, I think, everybody to kind of be able to keep everything in your head, and it's trying to figure out ways to kind of keep track of those things so that you can make it through. Spasticity is sort of a tightness. We have fancy definitions for this, but it's a tightness that's velocity dependent. What that means is, unlike where Parkinson's, where if you kind of just move that arm, it feels tight all the way through. Spasticity is something where if you move things very slowly, you don't feel tight. If you kind of jerk on a limb, it will catch and become really tight. The issue a lot of times with us is sometimes this might be hard. and it might be hard to kind of describe or see when you've been sitting in the clinic office and we made you wait for 30 minutes because we're running behind on a good day. You might not have a lot of spasticity, but you go and you walk for a few miles and you start kind of getting some issues where your knee starts to get tight or things like this. We're not going to have you walk for 2 miles during that appointment. And so we're going to kind of catch you at certain times where your symptoms may not be sort of at their worst. And so a lot of it is we kind of rely on you to kind of tell us about those things. And so sometimes those are good examples and why, again, exercise is important. I still remember one patient that ran 10 miles every day, and they would get to 9, they had progressive form of MS. And on mile 9 initially, it was like, my toes curl a little bit. I'm like, I would have never noticed that, a year later, it was by the time he got up to mile 7, and so he could keep track of that very well. And so that's sometimes one of the other things that's good about exercise is it gives us measures to know, like, how fast they're going. Do we need to try and look at other alternatives, canes, walkers? What are we needing to do to kind of make you be able to do the things that you want to do? We can use oral medicines. We use Botox. We can use intrathecal baclofen. That's kind of what that's shown there. So that it delivers the baclofen straight into your spinal canal. So there's a lot of different things that we can kind of sometimes try to help with these things. Mobility is kind of another big one. As you all know, we tend to see a lot of problems with our legs. They're long fibers, easier for things to kind of get hit. And so figuring out what the best strategy that's less invasive. Can we use sort of an AFO, so something that wraps around your ankle as opposed to putting you into a walker or something like this, and that's sometimes all that's needed. So trying to evaluate for that. Ampere is a big useful drug that's not a disease modifier. It's something that helps sort of signals make it through nerves, and I think I have a slide with this. So in areas where the insulation of the nerve has been destroyed, sort of here. So these are nerve fibers coming through on this slide. Where the nerve is ingrained, the insulation or the myelin is in red, and when you get it combined, it's yellow. This is a little bit more of a normal area. There's an area that's stripped, an area that's stripped. These areas, Ampere can sometimes help make signals go through that area. Here, that nerve's been cut, so there's no way Ampere is going to help you with that. And so it's trying to kind of find ways. And anything that increases signals to go through nerves, seizures is a side effect, and that's the main side effect that we see this. So if you've had a seizure, it's not a great drug, but if not, this is something to kind of think about with your provider. There's a lot of other symptoms. I'm running out of time, so I'm going to pass through a lot of these other things. But symptoms need to be recognized in order to be treated. There are treatments for many different symptoms. Sometimes they don't necessarily need to be treated, but kind of recognizing them. And sometimes it's behavioral stuff, and sometimes it's medications. It's good to kind of pick one or two things when you come into your appointments. As you know, our appointments tend to be fairly brief, so they need to be kind of focused a little bit on trying to deal with this, because you can see that a lot of these things, it's usually 2 or 3 things that are downstream that sometimes can have a huge effect on that symptom. Sometimes we have to refer to specialists, and it's important to set realistic expectations. So I think I'm cut off, and I'll go from there.
Thank you, Dr. Alvarez. Next, we have Dr. John Corboy, another MS specialty neurologist from the University of Colorado, who is giving us an overview of the disease-modifying therapies.
Thank you. Good morning, everybody. Thanks for coming. Thanks for giving us your Saturday morning on such a beautiful day. It's nice to see a lot of friendly faces. And let's see if I can make this work. So I'm going to talk about the presently available and some of the ones that are hopefully going to be available soon, at least in brief, of the disease-modifying therapies. And I'm not going to talk about all the different side effects and all this stuff. I'm going to talk in a very sort of large overview kind of approach as to different issues related to the use of the medications. So as I'm sure many of you are aware, there are a lot of different ways that we actually treat MS, not just the disease-modifying therapies. And Dr. Vollmer talked about several of these things: patient behavioral changes, exercise, vitamin D, smoking, perhaps low salt intake. Can you guys hear? Sorry. There's a new study just published, we've known about it for about a year, suggesting that high salt intake is bad for MS, low salt intake being perhaps better. So these are just patient behavioral changes. We also know that we treat acute attacks, for example, with steroids or plasma exchange. We also have a variety of symptomatic therapies you just heard about from Dr. Alvarez. But I'm going to talk mostly then about the so-called disease-modifying therapies. That is, those therapies that alter the fundamental natural history of the disease by decreasing relapses, decreasing changes on the scans that Dr. Vollmer described are very important, especially development of atrophy, as well as progression of disability, which is what we ultimately care about. So a lot of the concepts about the use of different therapies have evolved over time. And people were treating MS, even 75 years ago. All of the early therapies were sort of based on whatever the concept was with regard to what was the cause of MS, as was understood at that point in time. And so this is just a list of the different views and approaches that were available based on the concept that there was maybe an infection, or maybe there was a vitamin deficiency, or a vascular problem, which has recently come back up with CCSVI, for example. And all of these have been evolving over time. And these are some of the older approaches that were all essentially found to be ineffective. And the older experimental therapies that we've been using now for the last 20 to 25 years, based on the concept that this is likely an autoimmune disorder. The older therapies, many of these studies failed, like with Cytoxan and cyclophosphamide, azathioprine, these other medications. And they failed because these were generally pretty nonspecific immunotherapies. They affected multiple different cell types and multiple different parts of the immune system. They were relatively toxic, and a lot of them were in widely spaced patient populations, and it was difficult to measure outcomes. Ultimately, though, this led to a lot of scientific nihilism, the thought that you couldn't do anything for MS. And I think that a variety of different approaches have obviously changed that view, and our view now is that we can do quite a bit. So the modern therapy concepts are that we want to alter or subvert or somehow suppress the immune system, but typically we want to try and focus on relatively more narrow aspects of the immune system that would be hopefully relevant for MS, but not completely suppress the immune system. All of the presently available FDA-approved approaches are based on this concept in one way, shape, or form. But you could also, for example, try to enhance the normal repair mechanisms that exist inside the nervous system. And there are a variety of different studies ongoing right now looking at different molecules that might enhance normal repair. In addition, you could replace damaged cells, and this is where the concept of stem cells may come in. So there have been a variety of studies over the course of the last 10 to 12 years or so looking at primarily what are referred to as mesenchymal stem cells. But there now is the possibility of having cells that perhaps might be taken from the skin, and they might be reprogrammed to become generalized stem cells and reprogrammed again to become neural precursor cells. And perhaps using these types of cells from the patient's own skin would be allowing us to have cells that would be able to more directly replace damaged nervous system cells, especially if they're perhaps placed into the spinal fluid or into the brain proper. So there are a lot of different approaches that you might use to either try and suppress the problem or to repair or replace the damaged parts. But most of what we're going to talk about really has to do with suppression of the immune system in one form or another. And so the modern era of MS therapy really began in 1993 with the approval of interferon beta-1b, beta-seron, and then you can see all the subsequent medications that have been approved over the course of the last 21 years. And counting all the different doses and the different products and the different labels and everything else, there are now presently available in the United States 13 different products. And there are quite a few more to come. The most likely to be approved next will be alemtuzumab, and then after that, perhaps teclistamab, after that, perhaps ocrelizumab, and there are others as well, laquinimod, siponimod, and others. And notably, when you look at this long list, the thing that is impressive is that although the interferons are relatively similar to one another in terms of their mechanism of action, many of the rest of these are really unique and novel mechanisms of action. That is, they will have different ways that they might try and alter the effects of the immune system. And so for one person, one thing may work well. If that does not, however, there are other choices and other mechanisms of action that may actually be beneficial. And so that gets at the concept of how do these drugs work. And I'm not going to go into all the details of the chemistries of how these work. But it's, I think, notable to say that for the interferons and for glutathione acetate Copaxone, there are actually probably multiple different mechanisms of action by which they may work. There's not one single thing. And as we've sort of gone to the newer agents, some of them are more specific, and the monoclonal antibodies that I'll talk about in a little bit more detail are relatively actually quite specific. Fingolimod, for example, though, traps lymphocytes in lymph nodes, although it may actually have a direct effect on the central nervous system as well. Teriflunomide blocks the development of certain reactive lymphocytes, T cells and B cells. But the monoclonals, which are many of the newer medications, all of these are made in the lab antibodies, proteins, whose job it is to attach to other molecules on white blood cells and to delete those molecules, delete those cells from the repertoire of the immune system. Sometimes, for example, with rituximab and ocrelizumab, they actually kill those cells. But in other cases, for example, with natalizumab or Tysabri, they just bind to that cell and make it unavailable. So it could actually knock off a cell, get rid of it, or it might just make it inactive. And so several of the different types of monoclonals are noted there, and these monoclonals all will attach to the different molecules that are noted there. For example, natalizumab to alpha-4 integrin, alemtuzumab to CD52, et cetera. I would also comment specifically about rituximab and ocrelizumab, the CD20 molecules. It's interesting that these molecules, the CD20 is a molecule on the outside of B lymphocytes. And in the last 10 years or so, it's become much more apparent that the B lymphocyte is extremely important, as is the T lymphocyte. But for many years, the concept was to try and take away T lymphocytes. And actually, the therapies that were designed to try and remove T lymphocytes didn't really work very well, whereas the ones that are actually affecting the B lymphocytes do. So there's been a frame shift in our view of sort of the pathogenesis of the disease, in part based on how the mechanism of the action of these molecules works. So this is just, I just happen to use natalizumab as an example so you can see what a monoclonal antibody looks like. And you can see, let's see, I want to see if I can, oh, that was not so good. Carrie, go get, oh, I hit the wrong button. That's the button I wanted. Sorry. There we go. So, thank you. Escape, if you do that. Escape, thank you. Can always escape. So, so the monoclonal antibodies these are based on the normal antibodies that your immune system will make. And it's got these long chains and then these shorter chains. And then these CDRs, or complementary determining regions, actually interact with these molecules. I mentioned the CD20 molecule or the alpha-4 integrin. In the case of natalizumab, it interacts with the alpha-4 integrin and then binds that molecule, which is on the cell, and then that cell will not have the opportunity to do what it normally does, which is enter the nervous system and presumably cause an immune attack. So in the case of natalizumab, here's the white blood cell. It's got this alpha-4 integrin on it. These antibodies will attach to that and will not allow these cells to then pass into the nervous system. I don't know if you guys can see that over there. So the cells can't pass into the nervous system. If they can't do that, then they can't do the things that are bad. So all of the different monoclonal antibodies will interact with different molecules and will, in a different way, shape, or form, will alter the immune system to try to suppress the attack of the MS. So one of the biggest questions that we've been dealing with over the course of the last 20 years, 21 years, is when do we start and when do you stop disease-modifying therapies? There has been a lot of discussion about stopping, but with regard to starting, for many years the concept was, well, we'll just sort of wait and see, and we'll perhaps once you start to develop disability, maybe we'll start to treat you then. And over the course of the last 20 years, it's become quite apparent that that is not a good approach. The good approach is to try to treat people from the outset with disease-modifying therapies, even after the first attack, where numerous studies have shown that these medications can be effective in delaying the next attack, in reducing the relapse rate, and decreasing the accumulation of lesions, decreasing the accumulation of brain atrophy, and other things. There are some exceptions for pregnancy, for example, although many patients might use glutathione acetate while they're trying to get pregnant or even during pregnancy. And for so-called benign MS, if that exists, you know, a person who's maybe diagnosed in their 60s, they've already had 3 or 4 attacks, but they have essentially a normal exam. Maybe they have very few lesions on the scans. Perhaps that person doesn't even need to be treated. We don't have data one way or the other that they act really that differently, but they may well act differently. As alluded to by Dr. Vollmer, there's been a concept in the past that somehow progressive disease is different from relapsing forms of MS. There's no immunological, pathological, or other data that actually supports that approach, but it still is a challenge to know which of the progressive patients may or may not respond, and as discussed, age may be a significant factor. Certainly a 30-year-old with progressive MS we would treat just like any other 30-year-old patient. Perhaps a 75-year-old, the data does not suggest that the treatments would work as well. And then there's a real question as to when to stop, if ever, using these medications. And the real answer is there's not any significant data on this. One of our colleagues in Minnesota, Dr. Birnbaum, did perform a study, a very small study, offering people a trial off of disease-modifying therapies, and actually a significant number of people who were stable, and stable was defined as no acute attack and no change on scan for at least 5 years. And in their early to mid-60s, a substantial proportion of those patients actually can probably go off of disease-modifying therapies in that context. If you have a newly diagnosed patient at 60, that would not be the case at all, I don't think. So there's going to be a lot of context about that, and whenever we take a patient off of disease-modifying therapies, it's a trial, because we really don't have any data that says, we have this marker or that marker, or this in your blood, or this on your scan, or this about you that suggests that when you go off of therapy, that it's safe to go off of therapy. And there's really been almost no data about when it's safe to take someone off. There's been quite a bit of data showing that when patients are either involuntarily taken off or they lose insurance or other things like that, that they have recurrence of disease activity. So in general, we view treatments as indefinite, although I think we have to try and understand when it might be safe to try and do a trial off of medication as well. So what are the goals of the therapies for disease-modifying therapies? I wish we could say that the goal was to completely reverse MS and cure it, but unfortunately that's not a realistic goal with the medications that are presently available. But the goals of the things that we can measure are we can decrease the number of acute relapses or attacks. We can reduce perhaps the severity of attacks, the number of attacks that need steroids or hospitalizations. We can reduce the accumulation of new MRI lesions, and especially the progression of atrophy, which is related to disability over time, which is extremely important. Ultimately, we care about reducing the progression of disability because that's what gets people where they live, how do they function every day. There is data from the original beta-seron trial when they followed the patients up 20 years later, and they looked at the people who originally went on beta-seron compared to the people who originally were in placebo group just for 2 years. So it's a 3-year study, 2 years, people were on placebo versus treated. They followed up with those people 20 years later. The people who started on the beta-seron first, not on placebo, had a reduction in their mortality rate 20 years later. So even just starting 2 years later on the beta-seron was associated with an increased mortality over a 20-year period of time. That's not something we measure a lot because we don't have a lot of 20-year studies, but it's notable that that was the outcome. But ultimately, we also would like to stabilize or improve patient quality of life. We're interested very much in patient-reported outcomes. We can measure attacks and all this other stuff, but it's the patients who tell us, well, yeah, but this is how I feel, you know, when I'm taking this drug or that drug, or if I'm not taking this drug or that drug, this is how I function. I'm working or I'm not working. I'm going out with my friends or I'm not going out with my friends. The things that matter to the patient, I think there's been a sea change in terms of how we view the importance of those things is quite important, as in addition to the things that we measure as the physician. But ultimately, as Dr. Vollmer suggested quite clearly, we're interested in maintaining lifelong brain health, and that's the ultimate goal. I would also add to that maybe spine as well. I'm a big fan of the spinal cord as well. Both of them are important, but when we see a patient for the first time, we're interested in saying, what is this person going to look like 10 years from now, 20 years from now, 30 years from now? And that's what we're aiming for. We're aiming for lifelong brain health. So those are the goals. And then how do we measure that? We measure that again with the things that we can talk about. Relapses, annualized relapse rate, the time to the next relapse, percent free of relapses, severity of relapses, disability with a variety of different scales. And the scale that we use most commonly in studies is the so-called extended disability status scale, which is a measure, say, one number scale from 0 to 10, but it's a subscale, it's a variety of different subscales that are all put together to make one number. And movement on this scale is consistent with the evolution of disability. So we have a patient with a normal exam, minimal disability, some trouble with walking, requiring assistance, and then patients who have more significant disease activity. So this has been something that's been in use for roughly 50 years now, also referred to as the Kurtzky scale. Then there are a variety of different MRI scan measures that we also look at, short-term measures as well as long-term measures. And as Dr. Vollmer described, the long-term measures are the ones that are ultimately more important because they're the ones that are linked primarily to the evolution of disability, especially brain atrophy. I think over the last 5 to 10 years, the biggest change that we've had in terms of what we measure and how these medications work is the effect that they have on brain atrophy. And that's a very large initiative in our center to try and understand the factors that are associated with that and see if we can actually take patients who are having perhaps enhanced atrophy evolution and reduce that to the normal level of atrophy that we all have. We all, by the way, everybody in this room, with or without MS, after about age 35, you start to have shrinkage of your brain by about 0.2% per year. And we would like to have patients with MS have that or better. So what do we call a definition of treatment failure or success? How do we measure that? That's very difficult. When we first had beta-seron as the only drug available and the earlier medications, it was not really clear how we would call that. Would just having one attack a year compared to 2 attacks a year, would that be considered a success or was that a failure? It might be better than you were before, but is that good enough? And we don't have very good measures of failure, especially as it relates to when would we like to consider a change in medication. Is there a standard that we would all say that if you have this number of attacks or this amount of change on your MRI scan or this amount of change on your examination with the EDSS, is that enough change that we would say, oh, that's enough, we should stop using medicine X and go to medicine Y? And the answer is there's no one way that everybody amongst the MS doctors agree upon as to what a failure is. We're trying to move towards this definition of disease activity-free status or no evidence of disease activity or no apparent disease activity. I personally prefer that one. It's just easier to remember for me. And it's some combination of relapses, change in EDSS, change in MRI scan, and as Dr. Vollmer mentioned, the addition of other MRI measures, especially atrophy measures, would potentially make this a more robust measure. I think everybody would agree that if there's no evidence of disease activity or no apparent disease activity, that would be a good thing. And we talk about that a lot in the office, but then there's still some subtle things that we'd like to know. That's the things that we can measure, but what about those patient-reported outcomes? Is the patient feeling that there's no change, or is there even perhaps improvement in their functional capacity? And ultimately, we've talked about, for the last 20 years, getting less worse. I think it's also time we can start talking about getting better. And many of the newer drug trials are measuring, is there not only less of a worsening in the EDSS, but is there improvement on average in the EDSS? Is there improvement in various patient-reported outcomes? So I think our shift is starting to go towards the other direction and actually measuring not only getting less worse, but also perhaps getting better. And so this is just a summary table taken from a recent article from Bruce Cree, which looks at, this is another variation of the slide that Dr. Vollmer showed, showing some of the comparisons of so-called disease activity-free status for the various different trials, and showing on the far right differences between placebo and the treatment groups for the percentage of patients who at the end of typically 2 years had disease activity-free status or no evident disease activity. And so you can still see, even with the treated groups though, that that's not 100%. None of these medications will, so far as we can tell, produce no evidence of disease activity in anywhere near 100% of the patients. And so we still have quite a bit of work to do using this as a marker of disease activity. And as I alluded to, there are other things that you might add to that concept in terms of, is there really no evidence of disease activity? So I mentioned relapses and disability progression, maybe MRIs. But what about neuropsychological measures, cognitive measures, other measures? So there might be a more robust way we can try and define what really is no evidence of disease activity or no apparent disease activity that's ongoing. And so this is a fluid model. This is a fluid concept as to how we might measure what kind of activity is going on when a patient is on a medication X or Y. So what about implementation of modern immunotherapy? So this is still primarily the concept that exists for use of these various 13 different molecules and doses that are available right now. And many people still refer to so-called first-line therapy, which generally includes the older medications. It's also referred to platform therapy, and it's the use of the ABCR or the CRAB drugs primarily. These are the older medications that have a very high safety profile, very low risk overall. Modest reward, perhaps. I think the data, it's fair to say, suggests that number of relapses, progression of disability, atrophy data, as shown by Dr. Vollmer, is less robust than it is with some of the newer medications. And some of the tolerance and compliance issues, sometimes they're difficult to take. Some of the side effects are more challenging. They may have a lower cost. That's a very relative term, as I'm sure you're all aware, with relative meaning starting at about $5,000 to $6,000 per month for these medications. But the concept being that you would escalate from one of these first-line therapies should you develop more problems by whatever definition, either NIDA or whatever definition your physician you would use, to a so-called second-line therapy or even third-line therapy or now fourth-line therapy with the various different medications. But the concept being to escalate from one of the older medications to the newer medications. This is, I still think, the most common way throughout the United States that people are treated. And the question is, does that make sense? And the newer medications perhaps have a higher risk, at least a higher risk that's perceived, and it might be variable depending upon the patient. For example, with natalizumab, your risk is going to be very different if you are exposed to the JC virus that causes the complication PML or not. With fingolimod, Gilenya, your risk is going to be very different based on if you have diabetes or a history of uveitis or if you have heart disease compared to not. So the risk is going to be managed very differently in these patients because there perhaps are challenges in that regard. But there's perhaps greater reward as well. Many of the studies, especially the direct comparative studies, not enough of which have been done yet, suggest that the newer medications perhaps are more efficacious. And I think Dr. Vollmer showed you his data that was consistent with that. There's also, in many respects, better tolerance and compliance. The oral medications are oftentimes more easily taken, although not necessarily so. They certainly have side effects as well. And they perhaps have higher costs, so that oftentimes, based primarily on cost, a lot of the insurance companies will require failure of 1, 2, or even in some cases 3 different medications before getting access to some other medications. And that is the standard that exists in the United States today. And so if you look at some of the comparison data between the different medications, a lot of the comparisons between the older medications show not a huge difference between the interferons and glatiramer acetate. Some would argue that the higher dose interferons are certainly more efficacious than the lower dose interferons. Perhaps that's the case, but there's not a very large difference between these, for example, with regard to looking at relapse rates. When there have been comparisons of annualized relapse rates with the newer MS agents versus placebo, as opposed to the older agents, which have about 30% risk of reduction in relapse rate, the newer medications actually show quite a more robust difference, noting that you're comparing different studies done at different times and not done exactly the same way, so it's difficult to make direct comparisons. We should always keep that in mind. But it is notable that, with the exception of teriflunomide, Aubagio, all of the newer agents, and I listed also here alemtuzumab, which is not yet approved, but which has been compared to interferon, showed a very robust drop in annualized relapse rate compared to the comparator. So the newer medications appear to be more efficacious. And this is a slide, again, noting that, again, it's difficult to compare different trials done at different times, but when you look at relative reduction in relapse rate, percentage of patients who are relapse-free at 2 years, reduction in disability compared to placebo, in general, the newer therapies would be favorable from an efficacy point of view compared to the older therapies. And there have been direct comparison trials of first-line therapies to one another. So, for example, interferons of a variety of different types compared to glatiramer acetate or Copaxone, a variety of different trials. There's also been the so-called CombiRx trial, which was, several publications have come from that recently, which was a comparison of Avonex interferon beta-1a to Copaxone to a combination of the two. And the majority of these trials have really shown very little, if any, significant differences between the older therapies. And this is just one, the REGARD trial, comparing interferon beta-1a versus glatiramer acetate, and showed really no difference with the main outcome measures related to relapse, and some very similar outcomes when it came to patients free from relapse, for example, or annualized relapse rate, almost identical numbers, maybe some very modest differences in the total number of enhancing lesions, maybe less than the interferon group, but very modest differences. There have been a variety of studies, though, comparing the new agents directly to the older agents, and, the Transforms trial, Confirm trial, the MS CARE trials, and then some studies that are newer with medications that are just newly approved, such as teriflunomide, are not yet approved, ocrelizumab, or the daclizumab trial versus interferon beta-1a, and that actually those data are out, and interferon beta-1a was not as good as the daclizumab. Essentially, in all of these cases, the newer agents were directly compared to and were superior, although I would say with regard to the BG12 or dimethylfumaric acid Tecfidera versus placebo and versus glatiramer acetate, this is really sort of a post hoc analysis, and not all of the outcomes were better with regard to the comparison of Tecfidera to glatiramer acetate. So this is one example. This is the Transforms trial. This is Gilenya or fingolimod compared to interferon beta-1a, which is Rebif in this case. And then if you look at the annualized relapse rate, there are 2 doses of the fingolimod, was less compared to the interferon beta-1a. And I'm sorry, that's a mistake. That's actually Avonex. It's not Rebif, sorry. And then also, if you look at other outcome measures, relapses, a percentage of patients who are free from relapses was also different. So when it comes to determinants of therapy choice, there are a lot of issues that will come up. I just mentioned some with regard to efficacy. But there's ease of use, there's mode of administration, there are side effects, risk issues, and cost issues, and then, of course, insurance issues, as well as doctor issues that will play a role. And I mentioned so-called step edits. So it's a very complicated concept to have patients come into the office for the first time and say, is there one medicine that everyone should be on? Well, I think that's clearly not the case. I think the appropriate thing is to try and figure out what is most important for that patient and what is, for example, is their pregnancy status, and all these other things that will make a very large difference with regard to the choice for the patients. But in our view, perhaps at the top of that list should be efficacy, because as Dr. Vollmer went through in great detail, how you get treated early on in the course of this illness will make a very large difference with how you look 10, 20, and 30 years later. And the best way today in 2014 that we know to do that is to use the most efficacious medications available and try to manage the risk that goes along with those. So here's that first-line therapy approach, escalation into second-line therapy. That's what the standard is pretty much right now. And how much time do we have left? 30 seconds. I'm going to skip through this then. And I'm going to get to the end. All right, so here's our standard today, escalation therapy. Start with a low-risk medication, perhaps one of the interferons. Perhaps some people will even still watch and wait, although we very rarely recommend that. And if you do well, sort of continue that indefinitely. But if you do poorly, then start to switch around. And again, not having a certain definition of what is doing poorly. And then ultimately, if you continue to do poorly on multiple medications, maybe check to see if someone's been exposed to the JC virus. If so, then maybe you wouldn't treat them with natalizumab, but if they have not been exposed, maybe you use natalizumab. And you might use these other sort of second or third line agents, fingolimod, Tecfidera, teriflunomide, et cetera. That's the standard right now. Another approach would be perhaps to focus on efficacy. And I think that this is perhaps the approach that we would suggest for the majority of patients. So focus on efficacy as the primary outcome measure. And if so, you could then, for example, and this is only one. There are many potential models. I'm not saying that this is the model for everybody, but this is one approach. Perhaps then look at their JC virus status. If someone is JC virus negative, perhaps use natalizumab, because I think the impression is that that's perhaps the most efficacious medicine available today. If they're JC virus positive, you go down a different tree. If they do well with JC virus negative patients, you might continue that indefinitely. If they do poorly, then you might need an alternative, and then you might go to other medications. We use rituximab, which is off-label, but ocrelizumab is a medicine that's very similar, which will potentially be approved shortly in the next couple of years. But the point being to focus on efficacy as the primary measure, and then to follow the trees down in various ways. And this, of course, will be variable for each patient. If you're a 30-year-old woman who's still trying to get pregnant, perhaps you wouldn't do this. Perhaps you might use glatiramer as your primary medication because it's a pregnancy category C. And a number of our patients will even continue to use that during pregnancy. So obviously, every patient will be different. Every patient will have different issues. Some patients will be JC virus positive, some will not. And so trying to use algorithms that will be based on individual patients, but focusing on efficacy as the primary outcome that we're trying to use when we make a desirable choice for that patient. So I think I'll stop there. We'll be happy to take questions, I think. And thank you all for coming. It's a beautiful day, so after we're done, we are going to have some sessions where we'll have breakout sessions talking about a variety of different things that are very important that have to do with symptoms and other things. We hope you'll be able to stay. If not, enjoy the rest of your day, and thanks for coming.
Thank you, Dr. Corboy. There was a question whether or not the physician slides are available. There is a link on the MS Center webpage that will take you to the various slides. I will now turn the mic over to Michaela again for a question and answer session.
If a patient is having no apparent disease activity on MRI but is still experiencing issues like worsening balance and falls, are they still able to switch to one of the newer disease-modifying therapies?
So that gets at the question of what does it really mean to have no evidence of disease activity? So those are the things that we can sort of measure. MRI scans are great in that regard. But what we don't have, and what Dr. Alvarez alluded to, is perhaps are there other biomarkers? Are there other things in the blood that might play a role? Is there some measure of inflammation in the blood that we haven't discovered yet that would tell us that even if we don't see a new scan change or if we don't have an acute attack, that is there's something still sort of underneath the surface that is showing us that there's inflammation. We need another marker or other markers that will help with that. What it may also get at, though, is what Dr. Vollmer spent some time talking about. That is this loss of brain reserve, cognitive reserve, neural reserve over time, and how much of that is going to be impacted by by any of these medications is less clear. So in addition, as Dr. Alvarez just alluded to, it could be that there's just some other intervening factor. Perhaps there's a urinary tract infection. Perhaps there's something else that's causing a pseudo-attack or pseudo-relapse that if you treat that, then you'll help make the patient return to their prior baseline. So there's all sorts of different things. I think the general answer is, though, that if you are continuing to have more problems in spite of no apparent disease activity, one option would be to try an alternative, but it doesn't necessarily change those other issues.
And just a couple comments. That I think the NEDA definitions are keeping evolving, so that the latest round is trying to be able to incorporate sort of the brain atrophy measures and things like that. I think that the difference a little bit is sort of disease activity from relapses versus the disease activity related to progression of disease. And that can be really hard to sometimes measure. If your progression is fatigue, if it's pain, if it's other things like this, those are things that a lot of times in our scales clinically don't get factored in, but are definitely going to have a huge effect in how you're doing. And so we still kind of need to keep adding to sort of how we define these things. But it's just impressive that we can sort of move on from the old definitions because we think we can beat those already and start to incorporate these other things. So I think that that's the hope, at least for the future.
If drug therapies suppress the immune system by design, does that make colds, flus, and pneumonia more dangerous?
I think it really varies sort of on the treatment. So most of the drugs that we're using today routinely really don't have a huge effect on those on things that we can measure, as long as we don't drastically reduce your antibody levels, your white counts, things like this, which is the reason that every time you see us, you start sort of getting a needle in your arm pretty much routinely. And so that's kind of what we're measuring. That's what we're trying to figure out, is just to make sure that we're not going too far, that you're not having kind of a bad reaction to that.
But the flip side, though, is that we do know that for many of the medications, and I was going to discuss with natalizumab specifically, just to use that as an example of this risk of PML, this rare brain infection caused by the JC virus. We do know that there sometimes are very specific things that may be risks related to infection that have to do with very specific reactivations of various molecules, such as the JC virus, or maybe tuberculosis, or maybe hepatitis, or maybe the chickenpox virus, which may cause shingles. So for reasons that are not completely understood, the newer medications especially may make you prone to one or more of reactivations of these prior infections. These are things that are typically on you or in you already, not things that you're exposed to in the environment necessarily. And we've all been exposed to, almost everybody in this room has been exposed to chickenpox in one way, shape, or form, or the younger amongst you may have had a vaccine. So there are unique things, specific things that are somewhat more challenging to understand. But I think what has been really notable is that we haven't seen perhaps more infections. Many of the studies show that there's not a huge increased risk overall of infections. Maybe some class of infections, but not dramatic. It's not like our patients, when they take drug X, Y, or Z, are just having infections all the time. That's just not the case. That's just not what we see.
We're nearly out of time, but could you each briefly comment on what inspires you to work with the MS population?
Well, I think for me is, in medicine we choose as physicians practices based on our own personalities and what we like to do. I think it's fair to say that none of us have surgical personalities. And for me, it was important to want to work with people and have a relationship with people for a long period of time. Surgeons, as important as they are, and I need a surgeon just like anybody else, I'm thrilled to have them. But that's not the kind of interaction that I really want to have with people. I want to have interaction with people where I get to know them as people, and I try to understand them at a very fundamental level and try and make a connection with them over a prolonged period of time. So for me, a condition like multiple sclerosis is almost ideal, but in addition, I happen to just train at a place that had a very big MS presence in the Department of Neurology, and it just seemed like a very fascinating condition, and also seemed like a condition that we could probably, in our lifetime, try and make a big dent in. And I think that's occurred, and I think that being part of that is very exciting personally, but watching the impact that we can have on patients is very gratifying.
I think I agree with pretty much all the answers you've gotten so far today. I mean, I think I sort of fell more into treating MS patients than sort of something I had planned out, and it was just sort of, it just seemed to kind of fit at each time I was trying to make a decision. I think the biggest example of why I ended up doing this is just looking around the room today and just kind of seeing the great presence of people here. It tends to be a population of patients that care about their health, that come in, ask great questions, want to educate, and want to learn themselves. And so it's just been a fun sort of ride for me.
Thank you, Dr. Corboy, Dr. Alvarez, and Michaela.
Dr. Vollmer, this question for you. How do you measure brain atrophy? This is a multi-part question. Do gray matter lesions occur first and then white matter? Can brain reserve increase with age?
So the way that, actually Dr. Mervalli should be answering this, he's the MRI expert in the group. So when you do an MRI, we have voxels or pixels, so small squares that have the color in it, and it's like the TV screen, you have little dots on them. So imagers can take the MRI and plot it as a histogram, as how gray or how dark those individual squares are, and that gives you some information about what kind of tissue you're looking at. And so using various algorithms, they can actually, they know what the size of the squares are. They simply add up the ones that have certain characteristics to them that represents gray matter or other ones that represent white matter, and you have the cubic millimeters brain volume. The technology is reproducible enough that within looking at studies with 30 patients per arm or greater, you can see changes in the range of 0.05% over the course of a year, which is very, very small. So it's a very sensitive technique. And you can sort it out by regions and other things. So you can look at just the temporal lobes, or you look at the motor strip, or you look at the thalami, which are deep nuclei. It's a very powerful bit of technology, and is being used to try to understand the different clinical presentations that we see. So in terms of whether gray matter or white matter come first, it appears they come on at the same time. There was a study published by Claudia Lucanetti, a colleague of ours up at Mayo. And basically, she gathered up brain biopsies from around the world that had been done on MS patients. Sometimes MS presents in a way that it looks like tumor, so we have to do a brain biopsy to sort that out. And then she characterized those brain biopsies in a very standardized way. And what she showed was that at their very first presentation, the very first attack with a white matter lesion, she still saw dying neurons in the cortex. Also, as I've said before, other studies, such as the group in Buffalo, have demonstrated that patients who present their very first attack already have brain volume loss that's significant and above what they would expect based on age. Does brain reserve increase with age? Yeah, theoretically you could. You can, by living a healthy lifestyle, optimizing diet, exercise, that's the cognitive reserve, that's that active part that you can induce by doing certain things to maintain brain health. Yeah, you can increase brain health over time.
Okay. If all forms of MS are the same disease, why are there so many variables and symptoms across populations? And what causes differences across populations in brain atrophy?
So I think both of us have to answer this. Think about other diseases, stroke, cancer, trauma. They all have variations. Every disease has a spectrum in terms of the symptoms that are associated with it. It has to do with the exact areas that are damaged, your previous health, other health issues that you've got. And also the immune attack on the nervous system could be modified by other environmental factors. As Dr. Mervalli was pointing out, there's an impact on the course of MS based on the infections you've had. So he's talking about infections that actually might help minimize MS damage, but there also are, there's a basis for thinking that certain kinds of infections might actually cause an immune response that in and of itself is not damaging the brain, but when it's combined with MS, it accelerates MS. And we have an example of that in another demyelinating disease of the peripheral nervous system called Guillain-Barré syndrome. So the variability is just that the world's complex, the brain's complex, and you're going to get variations. But the data that says that these are the same come from basically three sources, three studies. One is the natalizumab story. Natalizumab decreased brain MRI disease activity by 92%. So of the patients that we put into that study, which were variable, it didn't matter whether they were secondary progressive or relapse remitting. It didn't even matter if they were primary progressive in the later study that was reported. It decreased new lesion formation by 92%. That means that 90% of patients have at least the same biology and require those immune cells to cross the blood-brain barrier that Tysabri blocks. The second one was the anti-CD20 story. So this is rituximab and ocrelizumab. This is a monoclonal antibody that only kills B lymphocytes. It's the only thing it does. And it decreases MRI disease activity by almost 100%. So think what that means. One cell type, one type of immune cell, if you knock that cell type out, almost 100% of patients will stop having new lesion formation on their MRI. And then the third one is alemtuzumab, which is a newer drug that may be coming out in the United States in December. It's already available in Canada and Europe. And it's another powerful immunological therapy and has similar levels of treatment effect. So the point is we're using these very selective immunological therapies that are targeting single bits of biology. And we can show you that those bits of biology are critical to almost all MS patients. So I'm not saying that every MS patient has the same disease. What I'm saying is that the terms relapsing, remitting, secondary progressive, and primary progressive don't define different groups. So we need to come up with a different strategy.
I agree. No, but but no. If I may add I completely agree, honestly, and also other risk factors, smoking. That's an easy one that we can modify and changes the way MS will behave, regardless of genes, regardless of environmental factors. People who smoke, they do 10 times worse. So that's another factor that plays into the role of variability. And the other comment is that we tend to respond very well and react to what we see, and we tend to ignore what we don't see. And sometimes the differences among patients are supported with things we don't see. For example, brain atrophy. We are not good at capturing brain atrophy in clinics because, again, insurance might not pay for analysis of quantitative brain atrophy. When you look at more sophisticated MRI techniques, you see a lot of pathology that we might miss when we just simply look at standard MRIs. And those differences might account for very meaningful differences among patients that are independent of the disease subtype that we label in clinic, relapsing, remitting, primary progressive, secondary progressive. All patients have the same risk of having that atrophy, that brain atrophy, brain volume loss, and pathology that we might not see on MRIs.
I believe this was addressed in your presentation, but we kind of flew by it due to shorter time. What role does alcohol and marijuana play in disease risk and activity?
We don't really have trouble with alcoholism in MS. I mean, people just don't do it. And in terms of marijuana, I was on a presidential committee set up by the second Bush, George Bush, that was to look at the medicinal uses of marijuana. And so we reviewed all the data. We had lots of community sessions and heard from people. And there is evidence that medicinal marijuana, or at least THC, might have some role to play with spasticity or pain or a few other things. So at this point, I would say that what happened to that report, which is a book about that thick, is it got put into long-term storage by the Bush administration because it wasn't politically correct. But in that, if you do read it, there are reasons to think that you might be able to develop marijuana as a therapy for certain things with no more risk than what we have with other prescription drugs. Having said that, we don't have that data. So I don't know how to use marijuana in MS, so we don't have the kind of information we really need for that. You want to comment?
Yeah, so regarding alcohol and risk of MS, there was one study that showed only a slight trend of benefit, and take it with a grain of salt, of people who were wine drinkers early on, particularly females, and a lower risk of MS. Though don't think that red wine is going to decrease your risk of MS. Probably that study did not control for socioeconomical status, and probably the population that they looked at where wine drinkers may correspond to a higher socioeconomical status that actually had also other risk factors that play for that role. The rest of the studies show that alcohol, when it's abused, of course, will be associated with more falls, less control of balance, and poor outcomes. So I think the story of alcohol it's very much early. We don't know much about it, but if you use common sense, anything in excess is going to be bad, and anything in moderation might not affect the outcome. And if there is a benefit, probably we need to learn more about this relationship between red wine, Malbec from Argentina in particularly. So that's just my, and the risk of MS.
What are ideal vitamin D levels, and is any one source better than another?
So as we mentioned in the presentation, vitamin D deficiency is associated with both the increased risk of developing the disease as well as worse outcomes. In terms of levels, we try to target 50 to 90 nanograms per deciliter, and there is some variability in those levels. And as I mentioned before, we usually target 5,000 units daily, and we might have to go higher. Was that the question, or?
Yeah. Are there any meds that regenerate or destroyed myelin or reverse brain atrophy?
So let me just go back to the previous question on vitamin D. There's actually a presentation at a meeting I was at a couple years ago by experts in this area, and the most effective form of vitamin D is actually what you can buy over the counter. It's vitamin D3. You can buy it at any grocery store, in any pharmacy. They have 5,000 IU capsules. It's a very easy way to do it, and it's been studied and is safe. The prescription form is vitamin D2. It's only prescription form because it was the first one out 30 years ago. It's not because it's the best, and that form actually has a higher chance of leading to toxicity. So in general, I would say use the over-the-counter version and just use that one. And then the other question, I'm sorry, what was one?
Are there any medications that regenerate destroyed myelin or reverse brain atrophy?
There are no therapies that I know of at this point that can reverse brain atrophy, but they've not been studied in that way. So there's no data one way or the other. There are stem cell-based therapies, and then there are several monoclonal antibody-based therapies that are trying to induce repair in the nervous system. And so there's an anti-LINGO monoclonal antibody that is being developed by Biogen, and then there's 2 other antibodies being developed by Basanex and Accorda Therapeutics that affect signaling in the brain. What they're trying to do is to basically allow the brain's own stem cells to become active and to induce repair in the nervous system. And those have all completed phase 1, are now all headed into phase 2. Stem cells continue to move forward. So yes, I think for the first time in history, we have a half a dozen at least studies going on internationally that are designed to improve function and to repair the nervous system. Good for you.
Yeah, just a small plug here. So see brain repair as a natural mechanism that we all have, and CMS as your brain as a city in which you have a group of people that is creating mess and throwing garbage to the floor, and you have a crew of people that is trying to clean. That's your crew of brain repair that you have. So in order to enhance the crew that is cleaning, the first thing you have to do is get rid of the ones that are getting the mess, right? So by impacting your inflammation, by stopping inflammation to the brain, we are impacting now, even with other therapies that are being under investigation, the chances of your own mechanism for repair to take place. So the first step to enhance repair is to stop inflammation or damage. So by having highly effective therapies, we are indirectly allowing your own brain to repair by natural mechanisms. As Dr. Bolmer mentioned before, exercise is another way to also enhance natural ways to repair.
We are nearly out of time and taking a break soon, but if you could both tell us what inspires you to work with the MS population.
I'm a neurologist. I really don't have personal feelings. No, it's a great field. I did not go into it because I expected that we would have a lot of therapies. At the time that I started in this, it was because I had to pick out a specialty, so I was interested in treating the organ with the soul, and it was between the heart and the brain, and the heart's a pump, and so I chose the brain. And but the only thing I could really learn was immunology. So if you can do immunology, but you're a neurologist, you do MS. I did know about MS because I had an aunt of mine in Wyoming that had MS at an early age. Unfortunately, it was very aggressive and led to early death. So it's a logical disease, but it's a disease that's really benefited by the advances in science, in the technology we have. And when I started, I really did not expect to be at this point where MS is one of the most rapidly evolving neurological diseases in terms of therapies. It's leading the way in many ways. And it actually is going to benefit a lot of other autoimmune diseases. So I know the drugs are expensive, but the fact that they're driving an engine that is helping us develop many different strategies for treating MS and will, I think, benefit people in a lot of different ways.
So I think my personal story has to do with my curiosity, and I'm a very curious person, and I found that by working with MS patients, establishing these long-term relationships with patients in which from the moment you help a patient take the first steps into diagnosis and you walk this journey with a patient, I'm constantly learning. My 2 sources of learning are my patients and my students in the classroom. And the third one now I realize my kids. So it is constant relationship I have with my patients are making me learn, and I think in that process we both benefit.
Thank you, Dr. Vollmer, Dr. Miravalle. We're going to break here.